Yes. Continuare esaminare sempre alla scelta di salvare sezione. The students who are students that's an important section.
मेरे से हेलो, 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 मैं हेलो,
कुछ नहीं लगा है।
ये तो स्लाइडर है, स्लाइडर है। हम नहीं करेंगे क्यों तो देख लेंगे सर। पेरिंग पे तो कर लिए तो सर अरे इसको पेरिंग पे तो कर सर, एक पेरिंग पे कराओ सिस्टम। पेरिंग पे करोगे आ रहा है पेरिंग पे तो करना पड़ता है लिस्ट स्मार्ट स्पीकर फोन में पेरिंग पे करोगे तभी तो आएगा। न्यू डिवाइस कर रहे हो ना। हाँ तो नहीं, उसको तो पेयर पे डालना पड़ेगा। अरे तुम्हारी ये बात है।
Morning, ladies and gentlemen. I, Dr. Akanksha, and I, Shreya Srivastav, on behalf of the Ministry of Health and Family Welfare, Government of India, welcome you all. It gives us an immense pleasure to extend our warm and heartfelt welcome to all in order to celebrate the 7th World Patient Safety Day on this beautiful morning. Here, ensuring patient safety holds the highest priority. To strengthen our collective efforts in this vital area, we have come together today with healthcare strategists, civil society representatives, patient organizations, policymakers, program managers, healthcare facility leaders, frontline providers, and patient families and caregivers.
your structure of structure. Today, National Institute of Health and Family Welfare in Sabha on behalf of everyone.
Envisioning a world where healthcare causes no harm and every patient receives safe and respectful care, patient safety has become a pressing global priority. Recognizing its importance, the 72nd World Health Assembly in 2021 adopted the Global Action on Patient Safety Resolution, establishing patient safety as an essential pillar of the universal health coverage agenda.
which structural rules और साथ सतत नंबर बनाया जाना है जिसका उद्देश्य मरीजों की सुरक्षा करें जागरूकता बढ़ाना है प्रत्येक वर्ष एक विशिष्ट थीम चुनी जाती है जो प्रमुख रोग की सुरक्षा चुनौतियों को संबोधित करती है जिससे जागरूकता बढ़ती है हम सब देखभाल प्रणाली में सुरक्षा को बढ़ाने के लिए वैश्विक प्रयासों को प्रोत्साहन मिलता है इस वर्ष की थीम है सेफ केयर फॉर दिस न्यूबॉर्न समझा और प्रत्येक बच्चे की सुरक्षित देखभाल यह थीम सही और समय पर निदान की महत्वपूर्ण भूमिका को निभाती करती है जो बच्चों की सुरक्षा गुणवत्तापूर्ण उपचार सुनिश्चित करने के लिए अनिवार्य है
In line with Sustainable Development Goal Target 3.2, the global goal is to end preventable deaths of newborn and children under 5 by reducing neonatal mortality to 12 and under 5 mortality to 25 per thousand live births. In India, the current neonatal mortality rate of 19 and under 5 mortality rate of 29 continued coordinated and innovative efforts are essential. Given children's unique vulnerabilities, even a single lapse in safety can have lasting consequences, underscoring a collective responsibility to ensure the highest standards of safe and quality care for every newborn and child.
Ministry of Health and Family Welfare, Government of India, has launched several initiatives under the National Health Mission to improve patient safety. The National Quality Assurance Standards, also known as NQAS, address various dimensions of diagnostic, clinical, and patient safety, ensuring quality care across all levels of health. In line with this year's World Patient Day Safety Theme, Safe care for every newborn and every child, and the slogan, Patient Safety of the Sun. Standards emphasize, to build a culture of safety right from the very beginning. Complementary initiatives such as Kayako promotes cleanliness, infection control, waste management, contribute to creating a safe environment for mothers, newborns, and children alike. Similarly, Mera Hospital empowers patients, caregivers, and families with effective feedback mechanisms, ensuring their active participation in improving the quality safety of the service.
Comments with today's event, I would request Dr. Rajiv Patni sir, Advisor, Quality and Patient Safety Division, National Health System Resource Center, please give the opening remarks and objectives of today's event. Over to you, sir.
नमस्कार, अभिनंदन और आप सबका हार्दिक स्वागत है. Good morning, everyone. On behalf of the UPS team at NHSRC and on behalf of the Ministry of Health, it's my privilege today to extend a hearty welcome to all our colleagues who are here with us today in celebration of World Patient Safety Day. I extend a special welcome to Air Commodore Ranjan Chaudhary sir, GB Singh, Dr. Sheikh Shrivastava ji. A special welcome to all our colleagues from the states. You're the ones who are responsible, who are the reason for the success of the quality movement in the country. We extend a very hearty welcome also to all the development partners and everyone who's come from the academic institutions and everyone who's here because they're passionate about patient safety, about quality, and they're already working in this field. Must have noticed there's been some changes in the program and some changes all around. Those from Delhi would have noticed that the sky is blue and the air is clean. Those from outside Delhi, I would like to remind you that this is not what it is like. My team has put in a lot of special efforts to get the skies scrubbed for you, invite the clouds, and make this a wonderful day for all of us. There's another change. The chief guest, additional secretary and mission director, election. The joint secretary policy was a guest of honor, and the director NHM. They've been called in urgently for a meeting with health secretary. Speaking for myself, all I can say is we can't even imagine the kind of pressures and competing priorities that our people in the ministry they work on. But ma'am has assured us she'll be here with us. So the main inaugural is 50 to 1 o'clock. But we will continue with the health session. To set things in perspective, the theme has we are all aware of, and the theme this year being safe care for every newborn and every child with the slogan patient safety from the start. Now, the start of this patient safety day was supposed to be on 17th September, but as we are all aware, on the same day, the Swasth Nari Sashakt Parivar Abhiyan was launched, which carried on for 2 weeks. And I'm sure when ma'am arrives here, she will share with us the huge success of the program that was. It sort of is judicious as well, because safe childhood starts with safe mother. So why do we celebrate Patient Safety Day? I do not need to remind you about it. Despite our best efforts, some things will slip through and will cause harm to the patients. So this is a day to remind us, to create awareness, and to have a collective resolve and commitment towards patient safety. So I applaud all of you who are already working in this field and be taking it. Every year, WHO gives a new theme. This is the 7th World Patient Safety Day. And on this day, theme is children and newborns. Why children? Because children are special, they are tender, they are the future. And children do not have the agency to speak for themselves. They depend on adults to speak. Their needs are different from adults. The safety margin is much, much narrower with children. And we are glad that we are focusing on this very important segment, which is our future. anything goes wrong in this delicate stage will not only have immediate impact, will also have impact later in the life, will impact their productivity, their participation as responsible citizens. Now, the responsibility for patient safety rests not only with healthcare organizations and doctors and healthcare workers, it rests with everyone, starting from the leadership and the policymakers. It rests with all the development partners who support us in our ventures, in our endeavors. It also rests with the caregivers and parents and the communities. We need to all come together, promote safety for children and newborn amongst us. There are 5 goals which have been laid out, and we have domain experts who will be speaking on each of these goals, and we will be starting off with the technical session soon. So on behalf of the team, I once again extend a warm welcome to our esteemed faculty who will be helming the technical sessions. We are aware of the different dimensions of NQAS, and I'm very happy to share just last month, we have crossed 41,000 certified facilities, and the credit goes to all of them. The target for us is 50% certified facilities by December 25 and 100% by December 26. I'm new on this platform, but I'm confident that together we certainly will achieve this target. Some more developments that have taken place in the last 1 year, IPHL standards have been launched, and I'm very happy to share 2 facilities came forward immediately, and they have been assessed last month, and we'll be getting the scores and the results very soon. We are also moving forward in another very important direction, that is healthcare associated infections. Guidelines for surveillance and reporting of which were launched in Chennai by ASMD MAD in August or last week of August. A copy of each these guidelines is there in your conference. We'll request you to go through these guidelines and take this endeavor forward, implement HAI guidelines, reporting and surveillance. We will have the formal rollout and launching and training very soon. But in the meanwhile, we thought it would be a good idea for you to take this guidelines. With this, I'll stop here. Once again, a very warm welcome to all our guests and partners. And we look forward to interacting with all of you as through the day, because learning has to be cross-cutting across dimensions. Learning has to be from each other. Learning cannot be achieved in silos, and healthcare quality definitely cannot be achieved in silos. It requires us all to put our hands together and work together. My best wishes and namaskar once again.
Thank you. Thank you so much, sir. With this, we shall proceed towards the technical sessions. In these sessions, we will be hearing from distinguished speakers from across the country, each an expert in their field, sharing their valuable insights on the theme Safe Care for Every Newborn and Every Child, aligned with World Patient Safety Day 2025. I would like to call upon Dr. Deepika Sharma ma'am, lead consultant, Quality and Patient Safety Division, NHSRC, to share the learnings from the analysis of Sakushal self-assessment scores of facilities across the country. With over 15 years of experience in the public health system, has played key role in developing important technical guidelines and policies such as NQAS, Kayakal, Lakshya, Swachh Swasth Sarvatra, and the Patient Safety Framework, among others. Over to you, ma'am.
Technically, I'm supposed to come in after my lunch, but because of the change in this particular schedule, I came little first. So, as you know, like till this PPT thing got sorted out, I just start with an overview because I'm going to give you that an overview about that how we are, collecting the data in the Sakushal and what type of reflection they are coming in the Sakushal. So all of us understand one thing very well, that is your unsafe care contributes significantly in the newborn as well as child mortality as well as long-term morbidity. There are estimations from the WHO and other global agencies which says that particularly harmful incidence affect 1 out of 2 children in the pediatric wards, as well as 9 out of 10 children in critical care units. And these estimations are further reflected by some other agencies also, like if you can see the global estimation of the harmful medical care, which is a study mostly quoted in the patient safety. And this particular study is basically analytic modeling. This study usually says that approx 4.71 million patients get affected by the adverse event out of 421 million adverse event, which seems to be 10%. But if you look a little more critically, you will be surprised to know that 2/3 of such events takes place in the low middle income group countries. A recent study of PLOS of the medicine, this studies has done a kind of analysis, particularly of the newborn and child care. And these studies say that which was basically done in 32 hospitals, followed by they have taken a follow-up of 33,000 children, and the study basically says that 1 out of 2 patient, or another word I can say that 4 to 54% of the children's, they encounter at least one preventable harm in the ward. And similarly, 7 to 92% of the children, they get encounter harm, particularly in the critical care units. So this is just kind of reflection. And in India, we don't have much data available about the harm which are taking place in the children while they are hospitalized in any type of the care setting. But Government of India is very well aware about this particular problem. So since beginning of the inception in 2013, we have incorporated patient safety its component as a part of it. Later on, in 2021, we came up with the Muskaan guideline. And if you look into the Muskaan guideline, one of the main criteria of the Muskan guideline is the safety of the newborn as well as the children. So we ensure that particularly through their benchmark key performance indicators also and other ways while we are assessing the facility through the Muskan. We have further strengthened this particular initiative through the Sakushal, which we have launched in 2022, where the initiative is started for all the district hospital and the people who are not knowing about the Sakushal, it is basically patient safety self-assessment tool for the secondary care institution. And based on this particular tool, facilities are supposed to assess themselves biannually. For that, we usually train the facilities through their states. They constitute the teams, and after constituting the team, they do the assessment. And final scores are submitted to their districts as well as to the states. If I look a little beyond the Sakushal have 4 areas of concern, and then in the district hospital we have total 16 standard, 80 measurable element, and assess the safety of a district hospital we have 400 checkpoints. If I look a little beyond this particular section, you will be able to see that specifically when we are talking about first area of concern, which is about the safe patient processes, here we are trying to measure the standardization of the clinical care protocols, medication safety, surgical safety, your documentation, communication. In area of concern B, particularly clinical risk management, we look for the incident reporting, your clinical audits, morbidity, mortality audits, risk management, and whether there is some safety culture at place in the healthcare facilities. When we look further, then the area of concern C, which is about the safe care environment, and over here we look for the infrastructure safety, your safety signages and zoning, security and dignity. But this area of concern is beyond only the safety component because it includes many things such as human factor and ergonomics in terms of the patient safety. Then area of concern D, patient safety system. When we talk about this section, it talk about the leadership, your policies and protocols, monitoring and evaluation, and of course the patient and family engagements, etc. also. Now, this is just background of the Sakushal, and as I said that we did a preliminary analysis of the Sakushal scores which are submitted by the states. So I will show you that particular analysis, but before that, if you look into the newborn and child safety, we have taken into consideration the specific standard, such as, of course, patient identification, prevention of harm, medication safety, everything is there. But apart from that, few critical components like room temperature, that is also taken into consideration. Then essential newborn care, postnatal care, immunization safety, and early identification of the signages, and of course management of the children at a time is also taken into consideration. Then of course in child care, all the components are there, but apart from that particular components, we have also considered your comprehensive lactation management units, your DEICs, where we are ensuring that the patient will get the identified or for the management for their 4Ds, etc., into this particular section. Now, when I look into the Sakushal scoring as such, so there is very heartful information which is coming. Now, we have started Sakushal journey in 2022. In 2023, we got the response from only 237 district hospitals. And this response has increased to 37%. And this year, only district hospital, if I look into, then 502 district hospital has conducted the Sakushal assessment in their healthcare facility. This year, UT of Andaman, Chandigarh, Goa, Ladakh, Lakshadweep and Jharkhand, because of some reason they are not able to do this particular assessment. Surprising, Chandigarh, Goa and Jharkhand has participated last year, but this year they are not able to do this particular assessment. If we look into a more critical about this particular data, if I go into the number, then almost 17 states and UTs have conducted the assessment in more than 75% of the district hospitals in the state. While there are some states, 5 to 6 states, where the assessment is conducted only in the 15 to 75%, and there are few states where the assessment is conducted in less than 50% of the district hospitals. If I look into the score, so country's median score is coming 72%, which is 18% increase from the last year. And you can very well see the same picture when we are looking into the different areas of concern. In these particular area of concern, also there is some changes seen. Apart from that, if you can compare the median score, you will find it out that in 2024, we have 42% of the district hospitals where the median score was less than 60%. This time, this has decreased to 28%. Between 60 to 80%, it is stagnant. There is no much change. While more than 80%, there is increase or jump, which is approximately 17 to 31%. And which is basically showing a positive trend toward the patient safety. But these people have started capturing the data in the patient safety. That is very heartening to know in this particular. If I will go a little further, as I said, we got the data from approx 739 facilities, out of which this year 237 regional hospitals have also conducted the social assessment, and that has also been reported. This year, 4 states which came into the picture in a big way, that is Dadra Nagar Haveli, Maharashtra, Manipur, and Karnataka, where they have conducted the 100% assessment of their district hospital, which is very heartening to know. These states was not there in last year, but this year they have participated in this particular section. These are the median score state-wise, and I'm not going or dwelling anything out of this particular slide, but this is an overall picture. But one correlation that we very well find it out, the state which are performing well in the INQAS, they are, doing good in the Sukushal also. While some states which are lagging behind because of any reason in the INQAS, their performance in terms of the Sukushal is also borderline. So there are few states like Arunachal, Nagaland, Sikkim, Bihar, Puducherry, Maharashtra, Kerala, and Assam. So they are almost on the borderline when we are looking into the overall median scores. Now, if I will talk about the each area of concern wise scorecard, then you will be able to find it out that in first area of concern, which is about the patient care processes, medication safety, prevention of harm, and communication. There is a jump of the 10 points in comparison to the last financial year. While in IPC, there is a jump of only 8 points in comparison to the last year, which is showing that IPC practices are stagnating somewhere. And we are very well aware about it because of in Kayakalp, INQAS, Lakshya, there is a lot of focus on the infection control practices. All the low-hanging fruits are now over. That's why we have come up with HAI surveillance standard guidebooks, where we are now bringing all the district hospital and your divisional hospital into a platform where we have a standardized definitions for the district hospital for HAI surveillance and the mechanism. And as Patni sir has mentioned in his speech, this guidebook is already in your kit, and we have launched this in Mahabalipuram just last month, and next month onward we are going to start the extensive training of the states on HAI surveillance guide. If I talk about area of concern B, which is about the clinical risk management, over here you can find it out that in general clinical services, specialty clinical services, and high-risk clinical processes, there is a jump of 10 points. But when it comes to RM and CHA, it is again stagnating because the jump is only, 6 point in this particular section. If I talk about area of concern C, which is about the safe care, Over here also, there is change of the 12 points in physical safety, human in hygiene control environment and sport maintenance. Coming to human factor ergonomics, there is jump of only 3 points, which is giving us kind of reflection that most of places the facilities are clueless that what they are supposed to do in terms of the human factor ergonomics. So this is an area where we need to pay the attention on this particular section. Area of concern D, which is about the patient safety system. Over here, in the leadership and patient engagement, scores are increasing, but the scores are stagnating, particularly when we are talking about reporting learning mechanism and training and capacity buildings, particularly ability at care. So, of course, we understand that reporting and learning is not that easy job. So states are trying to do manually in whatever the way they are able to do, but probably they required some hand holding into a digital platform for reporting of the safety data. So this I have already talked about when we have compared nationally certified healthcare facilities with non-certified healthcare facilities. So we found that the median score of the certified facilities are much better than your non-certified healthcare. As the theme of this year is the newborn and child safety, so we have tried to look into the department, specifically SNCU, pediatric ward, and NRC, and find it out that what is the trend going in these particular departments across the country. So when we have seen specifically to the SNCU, we found that your area of concern C, which is safe care environment, and area of concern D, which is basically your patient safety system. There we are underperforming, which is only 53% and 36%. But the same picture is not coming out of pediatric ward. Now, when I'm looking into pediatric ward and even NRCs, where even the N is comparatively less, that is 336 only, the same picture is not coming. So there are two things. One may be whatever the global data is saying, that there are more harms in the critical care unit. That is the case. Or there may be the chances we usually have a perception that SNCUs are better than other departments of the hospital. So there is a chance that there is underreporting or the over-reporting from the departments. So I urge to the states, please look into this data, particularly for the SNCU, because the median score, particularly in the SNCU, is coming very low. It is a kind of take-home message for us to also to look into if really the safety is a concern. We know that Sakushal is a self-reported data, and this analysis is based on the self-reported data, but we have to, it's a kind of alert or alarm for us to, function further. If I will look a little further, if in the standard wise also, you can see that standard B 2.3, which is about the clinical safety, there also in pediatric ward, the median score is coming 100%, while in SNCU, it is coming 80%. Again, the same thing, like whether the critical care department really have some problem or your pediatric wards are over-reporting, please have a look into your data. And we will share these analyzed sheet with each state. So we urge you to please critically look into. I will just conclude with 4 or 5 things only. One is that, as know, this year theme is the newborn and pediatric care. So newborn and child safety is the priority. So first of all, we request you to look and strengthen your critical care units. Also promote human factor ergonomics principle in the neonatal as well as the pediatric ward. So whatever the reflections I have shown you, that is across the hospital, that is not only specific to, one department. Only last 2 slides are specific to the department. Otherwise, it is overall picture which is coming up. Second key home message is that it's a time to, scale up the Sukushal. We are doing it very good in the district hospital. Now it's a time that we will, percolate it to the divisional hospital as well as high load community health center also. there is a need, as data is showing, there may be chances we are under-reporting or we are over-reporting the things. The mechanism within the healthcare facility, specifically for the peer review, is very, very much required. So that type of mechanism can be worked. And the third, of course, capacity building specifically in the clinical risk management, your reporting and learning mechanism. But apart from that, we have to think of if we can start simulation training, particularly for the patient safety, for the healthcare, so that whatever the gaps are coming, we are able to, plug that particular gaps. Last thing, data-driven monitoring. So Kushal, data is coming, and as we did the analysis and we are sharing that analysis with the state, we request you that whatever data coming to you, please at least start looking into, normal descriptive stats of that particular facilities. They are going to give you much more reflection, and this will be helpful when you are going for the INQUA certification or the Lakshya certification also. To look into the Kushal will be very simple, that whenever you are going into the INQUA's state assessment or the surveillance audits, please have a look into the Kushal checklist also. And we are with time we are integrating that systems together, so that there should not be n number of assessment to the healthcare facilities. And of course, if possible, your state have some digital platform, please include the safety indicator also the part of that particular platform. So with this, I will just say that safety is not option, it's a foundation. Let's promise to imbibe safety in every layer, whether it is policy or practice, and transform the harm into the health, dignity, and trust. Thank you. Thank you so much.
Thank you so much, ma'am. Newborn safety lies at the heart of quality healthcare delivery. Through the Sakushal initiative, we are taking a transformative stride towards making our health facilities safer, more accountable, and better equipped to provide consistent, high quality care to every newborn. To shed light on this topic, I would like to invite Dr. N. Rajkumar, Deputy Director, Maternal Health and Quality Assurance, Karnataka.
Morning all. Warm greetings from the state of Karnataka. I must, at the beginning itself, I must thank NHSRC, the aegis of Government of India, that patient safety is in the forefront in the hospitals, especially with the celebration of the World Patient Safety Day from 2020 onwards, as well as the focus on the quality standards to be achieved in the hospital settings. So the quality is in the forefront. The provision of safe quality services, provision of efficient quality services are in the forefront of our hospitals. I once again thank GOI for bringing the quality framework in all the hospitals in all the states. With this, I will be moving forward with respect to the state, what we have been doing. The state Karnataka, now we have built on the foundation laid by GOI through NHSRC with respect to the quality framework. And here we have implemented all the quality schemes, and that is the NQS, Muskan, Kushal, Lakshya, and among these, with today's theme being safe newborn and safe child. So I have included the Kushal and Muskan elements in my presentations, and some of the analysis has already been done and been conveyed by Dr. Deepika Sharma. Then with this, we have this patient safety as a fundamental element of healthcare. So from here, we are, as we all know, the theme that we don't have to do unnecessary harm or potential harm associated with provision. Unsafe hospital care ranks third amongst the causes of death globally of the heart disease and cancer. That is unsafe hospital care. So this is a word where we need to just think about it and how we can make safe patient care in our hospitals. We have the, with respect to the theme, that is this year's patient safety theme, that is newborn and child care. So these newborns are really vulnerable for the harm, what can be done or what they can undergo in the hospitals. So therefore, we need to focus especially on this, and unsafe care in the intrapartum and postnatal care can lead to lifelong consequences. And a single unsafe incident in childhood can have permanent negative consequences on a child's health overall development, making early interventions very crucial, making the safe care very crucial. Infant mortality rate rates, IMR in Karnataka shows gradual decline over the recent years thanks to Lakshya, the Muskan and Sakshan. It reflects the improved healthcare access. However, disparities still persist in the rural areas, rural and urban areas. We need to focus on that, indicating that need to targeted for targeted newborn safety interventions like Sekushal and Muskan. Common newborn health challenges: high rates of neonatal infections, low birth weight, stillbirths, and inadequate postnatal care still remain critical. These are the challenges affecting newborn safety, relating need for improved healthcare interventions. The gaps in the newborn healthcare services: we have limited access to skilled birth attendants, inconsistent essential newborn care practices, inadequate postnatal monitoring, and poor health infrastructure contribute to significant gaps in newborn care services. The overall which have been affected. And ensuring newborn safety is critical for reducing infant mortality and morbidity. Early identification and timely interventions improve health outcomes and support sustainable development goals related to child health. Karnataka is emerging as one of the state leading in quality interventions, promoting safety of child as well as all other patients in the hospital settings. And here we have implemented, as I said, Muskan and Sakushal. Over here, what I would like to say in Sakushal, apart from we started in 2023, and this is the third year which we have implemented Sakushal. First year we did it in district hospitals, and the next year we went and expanded this Sakushal to all the taluka level hospitals, that is block level hospitals. We have 148 block level hospitals and over 38 district level hospitals. So nearly 180 hospitals have implemented Sakushal in our state already, as conveyed in my previous speaker, that we need to expand Sakushal to taluk level hospitals and well-performing CHC or high delivery load CHC. Now we have identified 41 high delivery load CHCs that we will be able to implement very soon with respect to Sakushal, which will promote patient care and also helps in achieving national quality assurance standards at the respective hospitals. So 100% implementation in all the medical college hospitals, district hospitals, and all taluk hospitals. Our taluk hospitals are 100-bed hospitals. Some are 150 and some have gone up to 200 also, depending on whether we have a separate mother and child hospital wings attached to them. So overview of Sakushal, it has been told already by Dr. Deepika that it is a self-assessment tool for healthcare facilities to evaluate and improve patient safety and healthcare quality. The 4 areas: safe patient care, clinical risk, safe care, when patients have not repeated. Next, Muskan, we have the 4 departments: OPD, IPD, SNCU, and NRC. So, we did the rotation was that launch of Sakushal in the state in all the district hospitals. Then we expanded to all the taluk level hospitals, which are at least 100 bed and more than that. Now, something which we did, maybe I do not know whether it was special or something different. Now we did the surprise virtual review of certified PHS apart from the 10% of surprise assessments being conducted by NHSRC, we conduct at the state level surprise assessments for all the facilities with half an hour notice. And usually this we do during the evening hours between 6 to 8 p.m., which will reflect that time the number of human resource present over there and the quality of the services with respect to the preparedness we check over there. So that we have been doing. And we also have brought down certain policy changes for quality certification of all public health facilities. I will comment on the next slide. This in fact has added a fillip to our quality improvement process in the facilities. And these are the ones with respect to the certified facilities, mentoring and apart from the we do is we subject them to for various round of assessments. Okay, and it's not just that it happens. One round of self-assessment takes place, and as per the guidelines, more than 70% score, the district level facilities verify, and then we have a separate before the state level assessment. We have mentoring and assessment visits by state level team, and then we go for state assessment. And fifth is the national assessment. So we keep doing the assessments often. So apart from this, we have improved the quality of intrapartum care. Intrapartum care, over 50% of the maternal deaths and over the stillbirths and infant deaths happen because of the intrapartum care. So therefore, we need to improve our intrapartum care. So what we have done is we have the national certification. We have achieved 130 out of the 180. Out of the 180, we have 133 achieved national certification. And we have this Karnataka Advanced Real-Time and Comprehensive Cartography. So it's not only cartography, but it captures the entire gamut of the patient care from the first month of reporting to the health system to discharge at the time of delivery. So this cartography has all the elements like the reports coming well ahead and the referral mechanism and the intrapartum care. So this we have implemented, and we have done the extra training for all the nurses and doctors. And then through OSCE we keep conducting. Then we have the mentorship visits, as I told earlier. We have a policy decision at the cabinet level to achieve quality. I will tell you next slide. Then we have a virtual review of Lakshya certified, which I did, and then the ANCS guidelines, anti-corticosteroids guidelines. And now we are doing the reduce stillbirth audit also. We are doing it. So here, this is the special which we did. We did it. We gave a lot of right from 2015 to 2025, 10 years. We gave ample opportunities for the healthcare facilities participate in NQAS and see that the facilities get certified. But a certain level of commitment is required at all levels, especially at the facility level. The ownership from the facilities are found wanting. And for the reasons that quality is to be perceived by a single person alone or a nodal officer, the facility level, so many things. So we did a government order which came up policy decision that we will be encouraging them, but if they fail to do so, then we will be going for disincentivization. The Ayushman Bharat is that PMJ, Pradhan Mantri Jan Arogya Yojana, ABARK. We call Ayushman Bharat Arogya Karnataka. But we did much earlier to PMJ. So these are the ones which we have done. So now the 3 months which we gave them time to improve with respect to gaps, orientations and dissemination of information enquiries been done n number of times. Everybody knows it. Only thing is that ownership, that assessment, gaps, analysis, and gap closure, low-hanging fruits, those things which were required. Now I think they will be going now from October onwards. We'll already these 3 months we gave it in July. Now October we are starting the all this implementation of this order. Next, what we have got is we have the SQU, DQU as in other states. We monitor from here, and then we do the handholding. We guide the facilities as and when required, and then we have at the state level under the mission director NHM. We have a meeting where we discuss the gaps program wise with respect to maternal health. I'm also the nodal officer for maternal health. I give the gaps and also I explain to the mission director as to how the gaps will be closed, what the state needs to do, what the district needs to do, what the facility needs to do. Like that child health. Then we have all the IEC part, all other NCD, all the sections to come up with their gaps and then try to improve them by giving guidance to the districts and facilities. This is apart from what the state, what the district and the facility does it. So that is one thing which we have brought in. And of course, the mentoring which is happening by our NCOAS national assessors who are present in Karnataka, we make them do the mentoring of the facilities. So these are the Sakushal score, what we do in medical colleges. So average Sakushal score, all the four departments, 63%, district college, medical college 63%, district hospital 75%, Taluk hospital, which I said 148, 72%. So overall state average is at 70% with respect to Sakush. Then we have the Muskan certification. We have the auto certified 49 facilities we have got. The national, in fact, this number we have got for 18. Next, we have the Lakshya. We have 133 Lakshya national certified cities in our state. Then we have the NCOAS certification. Now 3001 we have reached, as Sir said, 50% mark. So by December 25, we should reach 50%. We are on course to reach 50%, and the remaining by the next year, the certification. Then this is our infant mortality, keeping with current today's theme of safe newborn and safe child. I have put only the infant mortality rate in Karnataka that trend over the last many years. Then we have the improvements. We have what who the newborn safety we have shown. So significant reduction in neonatal infections and specific cases. Then we have the improvement. We have improved the resuscitation protocols, standardized protocols. Then improved infection control measures. Then we have the enhanced gap identification, closing these gaps. Then capacity building, comprehensive training programs, hands-on training sessions, continuous medical education, quality improvement workshops, creation for infrastructure. Then we have the modernization of newborn care units. We have SNCUs developed across Taluk hospitals also. We have the equipment standardization, facility innovation like safety purpose, and the CCTV biometrics all have played to add to the quality work. So this is implementing Sakushal and Muskan significantly improves newborn safety by streamlining care processes. So this is our conclusion that if we can implement these two under the overall program of NQAS, and of course with Lakshya, the safe newborn starts from intrapartum period with Lakshya. So all these three, Lakshya, Muskan, and the Sakushal, will add Philip to the process of NCOAS, and we can achieve NCOAS certification. So in the next slides, I have all the gaps. I think those gaps have been explained by our previous speaker, Dr. Deepika Sharma. About this, just I'll quickly run through. Will not take much of time. So these are our average median score for the Muskan. Muskan added because of the safe newborn child. So key processes mapping and key process mapping. Those things are still where we identify non-value adding activity. Still, I think it is yet to pick up in most of the facilities. So that we need that the first focus. And then these quality methods and tools. We have quality methods, 2 methods, and quality tools. So for 7 tools, they need to be used properly to close the gaps. The facilities are not investing in that. So that maybe there we have, and rightly it has shown in our, it has reflected in our gap assessment. And defined values, quality policy objectives, those things, some of the things which I'm just commenting where it is less, where we need to improve. Okay, so these are, as we go up, these are the ones which are having good more than 70, and ethical management dilemmas, those things. Okay, so clinical care and safety indicators and try to reach benchmark also up, and maintenance of the facility, the indicators, statutory and regulatory requirement have improved. Okay, and national benchmarks also improved. These are the ones which have good scores. So this is the state level assessment score. Just skip this one. Okay. So this is the average Sakushal score in district hospitals and medical college, which Dr. Deepika Sharma has told overall from the national perspective. From our perspective, standard-wise we have done it, and probably reporting and learning systems we have to improve. 69% we have to improve over there. And these are the ones, safety in general healthcare in the social score, apart from the other things. And B2 is 87.4% Karnataka, where it reflects on the current theme, today's theme. And the Taluk hospital, which I was telling, block level hospitals, more than 100 bed hospitals. So reporting and learning. So gradually, if you can see that, yes, when it comes to district hospitals, yes, still quality, we have to improve over the taluka hospitals. However, we got now fair idea how the taluka hospitals are faring. So we can invest on this and then bring up overall quality. So I once again convey my congratulations to NHSRC for organizing this event and giving this opportunity to share our learnings and so that we can improve the quality, and there will be cross learnings from other states also, which we will take it. And thank you so much.
Thank you so much for the wonderful session, sir. Before moving forward, I would like to announce that we have arranged quiz stalls right outside this hall and at the same spot where the registrations were being done. We'll start sharp at 11:30. So I urge every one of you to please participate in that. You might even receive a prize if you are able to answer a few questions. Moving forward with the technical sessions, every newborn deserves a safe start to life. By targeting preventable causes of mortality and morbidity, we can ensure healthier beginnings and brighter futures for millions of children. To elaborate on this important subject, I would like to invite Dr. Nagalakshmi Tolimeli, State Quality Program Officer, NHM Andhra Pradesh, to please share her insights with us today. Over to you. Thank you for your kind words, ma'am. Good morning to all the dignitaries. Now, coming to today's topic for Andhra Pradesh is reduction of newborn mortality and morbidity. When coming to the statistics of Andhra Pradesh for the financial year 2024-25, we have NBSUs of 91 with an admissions of 2,624 and bed occupancy rate of 29%. And the number of discharges is 94% and referral is 4.5%. We are having SNCUs, including mini SNCUs in tribal areas, are about 85, and number of admissions for the financial year is 72,536. Out of his POR is 103 and discharge percentage is 88.52 and number of referrals is 4.7. Now coming to the actual topic of reduction in preventable newborn mortality and morbidity. Now our main aim target is achieving less than 12 per thousand live births by 2030. This is our major goal, which is according to the Sustainable Developmental Goals 3.2. As we know that we have reached already neonatal mortality rate, gradual reduction in neonatal mortality rate from 29 per thousand live births from 2013 to 14 to 20 by 2022. And at present we are at 90. The major causes of newborn deaths, which contribute more high percentage for preterm births, low birth weight, infections, birth asphyxia, congenital anomalies. How can we decrease these causes? There are key intervention areas where we have to take care in order to decrease these major causes for neonatal deaths. That include from the early stage, preconception period, antenatal care, care during labor and childbirth, immediate newborn care, care of elderly newborns, and care of small and sick newborns. And these all different areas. When coming to preconceptional area, we have to give counseling regarding first the general condition of the mother should be improved, correction of anemia, and strong family history relating to any congenital anomalies. We have to give counseling to them. And most of these preterm births can be reduced while giving good antenatal care. And you all know that we have different program initiatives.
giving care during labor, childbirth, and immediate newborn care, and care to healthy newborns, and for care to the sick and small. Now, we have different levels of interventions in order to cover all these four areas, like family and community intervention, next outreach sessions, next at facility based. When coming to the family and community interventions, we have to counsel the family members regarding postpartum early pregnancy and birth spacing, which is most important now, and maternal nutrition. This has been, we have almost been reaching to 100% by the program of HBNC, home-based newborn care, which has been giving education to the ASHA workers. We are trained ASHA workers for this process. And because of this, ASHAs go to the home for educating the caregivers, mother, regarding the maternal health and newborn care, so that they can identify danger signs and we can reduce neonatal mortality. When coming to outreach sessions, we all that we have different outreach interventions for maternal and child. For maternal, from the type of registration, early registration, we are having a target now early registration, because to improve her condition from the time of conception till the postnatal period. For this, we have to screen for anemia, which is still the major cause for maternal death. We have to screen anemia and complete tetanus immunization to the maternal health. And also, we have to screen for TORCH, HIV, HBsAg, VDRL, and ECHO. And in addition to that, we all know that regular checkup of blood pressure, weight, and nowadays the most common condition is also GDM, which was increasing. We have to screen for maternal gestational diabetes, which was nowadays most common, increasing in trend. So that is also most important. With the 104 services, we are already giving ECG monitoring also for every for every mother during the 5th month itself. And these screenings, if you find any interventions, then you can refer the mother at early stage and you can treat her at the early stage, and so that there won't be complication and during the delivery time to both mother and the baby. Coming to the child health, immunization, we all know that you're having universal immunization program, but we have to improve immediate BCG immunization, zero dose OPV, hepatitis B, and should complete 100% coverage of immunization according to our universal immunization schedule. Now coming to the facility-based interventions. Till now, we have given counseling at family, community, outreach, we have screened. But here, routine delivery, routine maternal care, and routine care to the newborn, here we have to manage special cases also by giving care for managing severe anemia like blood transfusions, managing which was because either she may be prior anemic or maybe because of PPH, whatever may be, the timely management of severe anemia will reduce maternal deaths. And also increasing trends for preeclampsia, GDM, hepatitis B, HIV, and RH diseases. All these should be managed, and the skills of the staff should be improved in order to increase the facility-based interventions for the maternal health. And for if you suspect a preterm delivery, timely antenatal corticosteroid should be administered. Coming to the newborn, nowadays we are having SNCUs and ICUs. These are operationalized and equipment standardization is done in order to improve the care of the newborn. And for preterm and to decrease respiratory distress, timely surfactant therapy should be given. And also sepsis. We usually write sepsis. That is not so simple. Whatever the cause, respiratory distress, low birth weight, preterm babies because of less immunity, they are born for more infections. And sepsis screening, timely screening of sepsis and timely administration of antibiotics will reduce neonatal mortality.
Because of these all interventions, there is impact of the increase in case fatality rate of up to 40% and infection-related deaths to decrease it to 20 to 30%. Then we are the major care is given at care at birth and postnatal period. Care at birth, we have different programs because we have increased our institutional deliveries from 39% to 89% according to the National Family Health Survey 5, because we have trained our skilled birth attendants in different initiative programs, how to manage newborn care, how to give care during labor, how to warm the baby, dry the baby. All these different initiatives have increased the institutional deliveries and confidence in our caregivers. And clean delivery practices. This is the most important step where we can reduce infection rate. Infections is mostly prevented if you practice clean delivery practices. So that this was given trainings in different stages like NSSK programs, FIM and CWA, all these programs, we have given trainings for different like doctor, staff, nurse, even IMNCA for even up to aims. This causes, this given a good impact of increasing birth asphyxia deaths for more than 25%. Then come to the postnatal and newborn care after delivery, which is the more because the newborn are very tender. We have to give thermal protection, early breastfeeding, vitamin K prophylaxis, weighing, and anomaly screening, kangaroo mother care. This is one of the golden step because we can increase bond between the mother and the baby and increase breastfeeding, improve and thermal protection. Now, coming to the sick and newborn babies, we have some screening and specialized care we have to monitor for, like critical congenital heart diseases, identifying thyroid abnormalities, hearing disorders, metabolic disorders, and also assessment of respiratory distress using different scores like Anderson's score, Dole's score. So, neurosonography for screening for intraventricular hemorrhage in newborns to know any internal bleed in the brain. We have to follow ventilator-associated pneumonia bundle protocol we should follow for ventilated babies and also central line associated bloodstream infections. Now, the government of India has started different programs in order to improve newborn care and reduce preventable newborn deaths. But when a systematic program implementation to different programs, like it was started in 2009 with NSSK programs for essential newborn care and resuscitation, and also in 2011, and it was started JSSK and for free maternal and newborn care and home-based neonatal care by Asha home visits. And in 2014, India Newborn Action Plan has started to scale up SNCUs, kangaroo mother care, and home-based newborn care. And we all know that 2019 Suman program, which is for giving respectable dignity, motherhood, and newborn care in order to prevent deaths. Okay, we have implementing different programs and we have different systems for monitoring indicators like birth registration and mortality registrations, birth registrations, and also we can know that the stillbirth rate, NMR, delivery and birth outcomes. We can know how much percentage of safe deliveries, percentage of preterm births, early care practices, how much percentage of newborn breastfeeding within the first one, within 1 hour. And we are improving healthcare infrastructure, that is percentage of SNCUs functional with kangaroo mother care units. By taking all these programs and giving, we are now achieved till now 29 to 20% for NMR per dozen live births. And we have increased the institutional deliveries from 39 to 89 percentage and early breastfeeding first in the first 1 hour to 40%. Because of all these home-based newborn care, which was scaled up nationwide, universal immunization coverage expandation. Then we are implementing all these programs, but how can we reach this less than 12% live birth, 12% per thousand live births? Wait, we have to strengthen continuum of care from the preconceptional period to postnatal period, capacity building of our staff to equip health workers and empower families hand-to-hand practices and quality assurance. Robust monitoring is the most important, and death audits so that we can know our gaps and we can analyze how to improve the work process and how can we reach the target. And service deliveries maintain high immunization and facility based care so that we can achieve our goal less than 12 per thousand live births by 2030. Most newborn deaths are preventable with known interventions. Together, we can ensure every child survives and thrives. So let us continue our journey. Thank you.
Thank you so much, ma'am, for this insightful session. The use of rapid improvement cycles represent a dynamic approach to enhancing newborn health outcomes by enabling continuous data-driven improvement in care processes and service delivery. To discuss on this subject, I would like to invite Dr. N. Muthukumaran Sir, HOD and Professor of Neonatology, Department of Neonatology, ICH Madras Medical College, Chennai, Tamil Nadu. Please share his insight with everyone. Over to you, sir.
Good afternoon. I think you are able to hear me. So just before the morning in the session, just before the session. So thank you very much for the organizers for giving us the opportunity. So on behalf of Tamil Nadu, we are presenting rapid improvement cycles for newborn health outcomes. Now, as far as the various why the improving newborn outcome is important. So every year, so when compared to adults, children are more prone. When compared to children, newborns are more, especially the newborns first day, 24 hours, then first week, then first month. That is very important. So the first 24 hours is very, very crucial. So when we compare the newborn death, the first 24 hours is most. That's why we promote every care for the antenatal, intranatal, then becomes the postnatal. So our SDG goal is 3.2. We are in a plan to reduce our NMR to below 12 by 2020. So along with all the concepts, RM and CHR, the Lakshya program, National Health Mission, Muskan, we are trying every quality and quantitative approaches to reduce our NMR and IMR and child health. So we are gradually decreasing our child mortality and NMR, IMR. So our Tamil Nadu NMR is around the single digit, around 8, 2023. Our IMR is around some 12 by the SRS 23 data. So the various causes for newborn death, always there is a major three causes. So asphyxia, prematurity, sepsis, other causes. Now, because of the various intervention, antenatal intervention, prevention of sepsis, hand washing, antibiotics, we are decreasing. But now the other problems are third cause, that is congenital anomalies. Now we are focusing more on the congenital and congenital heart disease. These are all the major problems. Still, some unexpected postnatal deaths are happening in the home, sudden influences are happening. So main death, prematurity, birth asphyxia, sepsis. So birth asphyxia, we are more giving priority for the intrapartum, care, partogram, all those things. So prematurity now because of the infertility centers, everywhere infertility centers, every corner we have infertility centers. Because the various cultural practices now infertility is more common around the population. So mainly because of the infertility, we have the prematurity. Babies are born very preterm. So the sepsis, almost the sepsis is everywhere. So from top to bottom, sepsis is everywhere. So common. So prevention of sepsis is more important than treatment of sepsis. So we have various challenges. So we have the clinical challenges in the hospital. We have prematurity, low birth weight, birth asphyxia, Now we are training all the people. Wherever there happens a delivery, there should be one person, either a staff nurse or a doctor. This is a staff nurse. Even in hilly tribal areas, they should know the basic steps of resuscitation. One trained person, because what will happen at the time of delivery, nobody knows. So we are training all the people. So we are training all the people, so all staff nurses in hilly areas, they are trained in basic resuscitation. And then neonatal sepsis and infection, those prevention of infection is more there. The hand washing. So various studies, evidence-based hand washing, hand washing. We are celebrating hand washing day. So hand washing is the most important thing. We should teach parents. They are going to handle the baby. After discharging the baby is going to the home. They should know the hand washing technique. That is the most important thing. Now the congenital anomalies. Now we are taking every step. Now the major part is congenital anomalies. So neural developmental problems, that is neural tube defects. Congenital heart disease, they are still the major problem now. Now in Tamil Nadu, in Madras, we are receiving all the cases of congenital heart disease to Chennai. Now we are improving. Now major cardiac surgeries are done. Even TGS, ATA, PVC, coarctation of aorta, all cardiac surgeries are done in the newborn periods. Even in Tamil Nadu, we have MOU with Apollo Hospital. We are doing in government setup, but also in private hospital also with the same insurance, PMGS, we are doing cardiac surgeries. And then early initiation of breastfeeding, exclusive breastfeeding, all those things. The administrative challenges, we have the gaps in newborn stabilization unit, infrastructures, the SNCUs, NICUs. We have the manpower shortage, HR. So HR is the most important thing wherever there is the problem, because primary care, secondary care, tertiary care. Now we are more in concentrating, all purity aspects are going for the primary health center. The HR shortage is very low. Then manpower shortages is patient high load. So our government is giving free services. So the load is more back to other things. We are not in a, so any patient having any difficulty, they can reach a primary center, they can reach a tertiary center. There is nothing like that. They should go step by step. Whereas now abroad, if you want to see a specialist, it's not easy. But emergency, they are taking care. But the elective cases in abroad, they should go step. To see a neurologist, it's not very easy in abroad. You can see from your friends in abroad. You can't. For a headache, you can see a neurologist in Tamil Nadu. Whereas in abroad, you can't see a neurologist for a headache. You should go step. That's the system. So and then other pain issues, so drugs, consumables, and also the monitoring systems, the gas in the referral process. Now after the 108 ambulance system, that is very much. So everywhere the 108 ambulance, we are able to get an ambulance. The baby can be referred within 1 hour to a one care. And then financial concerns for key activities. So all the studies, we have the different studies. So most of the studies, so we have the quantitative studies and qualitative studies. So quantitative studies, now it's the evidence-based approach. So previously, what our elders say, we will follow. Now the entire world is beginning the evidence-based medicine research. So what is the research available? What is the evidence available? So we have basically quantitative research, that is case control studies, cohort, RCTs. Qualitative studies. The qualitative studies are how to improve our qualities. That is the most important thing. Small things, quality. That is the rapid improvement cycle. So we have many qualitative improvement studies. We have PDSA cycle, the 5 whys, why the Socrates always should ask why it happens, what is the reason, why, when. So 5 whys. When we ask the questions, why it is happening, then the answer will slowly come. We can change. This is the 5 whys. So these are all the rapid improvement cycle, PDCA cycle, 5 whys, then the first-born analysis. These are all different quality improvement cycles. Now we are slowly going quality improvement. So how we can improve quality wise? So rapid improvement cycles is the quality improvement method identifies and implements changes to the systems. So mainly PDCA cycle. So plan, do, second act. All this is the PDCA cycle. So the 6 rapid improvement cycles, we have the antenatal period, we have the real-time partogram, how we can efficiently use, how can it decide what to be done. Then the presence of companion. Even in private hospitals, now we are allowing the husband be near the wife during the time of delivery. Even in, so usually always the female attendants are allowed, but in hospitals, even husbands are allowed to be with the wife during the time of delivery. So they have, mother have a better confidence that the mother can stay in during the labor pain, so they can see what happens during the delivery time. So the birth planning and the respectable maternity care, and also the management of referral protocols. If there is any problem, immediately the mother should be referred to other centers, secondary center or the tertiary care center. and the management of labor. So first stage, second stage, third stage of labor, and the essential newborn care. So immediate KMC, IKMC. So many things are we are implementing and practicing. So immediate care. So soon after the delivery, the baby is placed over the mother's abdomen, and we try the baby. So yeah, slowly, so many procedures. So delayed cot clamping, milking of cot lamp. So many we are practicing. So the emergency newborn care, and then a preterm care. The infection once the mother comes to the postnatal ward, we practice the infection prevention practice. So the rapid improvement PDSA cycle. So what are the plans? So for collecting the data, try in a small scale. In a small hospital, we can do 1 cycle, 2 cycle, 3 cycles. We can do. We can assess with our staff nurses, all the paramedical workers. We can sit and design small scale PDSA cycle, small cycle. We can do. Try what are the various problems faced on a small scale. Then we can implement all those things. Check what happens after we make some changes. For example, simple hand washing. Why our staff nurses are hand washing? What are the problems? Is there any difficulties in the dispenser problems? We can check whether for 1 month how many people are there. So the quantity is decreasing or not. We can small steps. Small steps we can check. And based upon that, we can learn. So first cycle, second cycle, third cycle, we always do. For example, kangaroo mother care, we do small kangaroo mother care cycles. So why the mother is not giving? So how many durations of kangaroo? What are the basic problems? Chair is the problem. So the reclining chair, height of the chair. Then other people also, the father can give kangaroo. So father, so what kangaroo father care, KFC. So we have put a board, KFC, like KFC money. So kangaroo father care. KMC is kangaroo mother care. We KFC. So the kangaroo father care, KFC. Just so even one elder sibling has come. He has given care for her sister. So one elder sibling mother has gone for some other worker. So the various methods we can promote kangaroo mother. Small the PDSA cycle we can do. So many things. So whenever we have a neonatal sepsis, how to prevent sepsis, hand washing among healthcare workers, parents, for the problems we can identify any getting problems or using the problems or the timing 2 minutes washing, all those things we can do. We can implement PV. We can identify how it decreases the infection rate among the newborns. So whenever when we see our hands are white, I think there is no infection. If it is only dirt only, we think it is something dirt, so we have some infection. So then birth asphyxia problems. So mainly intrapartum asphyxia, we don't say always the birth asphyxia, always it is from the antenatal period, intranatal period, postnatal period. So the baby has suffered from the intrauterine itself. Mainly the partogram, how to fetal heart rate monitoring partogram, how to improve the partogram. So fetal heart rate monitoring, that is important. Then take decisions based upon the partogram, heart rate decelerations, accelerations, rapid decisions. That's very important. So why people are, though the partogram graph is there, why the people are not using all those charts? We can identify the problem, the difficulties, whether externals or some big hospital, they don't have the enough partogram instruments to record the heart rate. Then reading of the small cycles we can do, identify the problems, rectify the problem. We can see how it is the main aspects. Then prematurity, the main cause is then antenatal steroids. So improve the nutrition of the mother. So during our state level meeting, so for so many years we are doing an iron, but still anemia is still problem. Now iron folic acid to the mother. Now we are programming for iron folic acid to adolescent. So now still anemia is a major problem. We are improving the nutrition. So small state level policy makers, they take decisions. It's a problem in taking iron, we can say, because of the color the mother thinks. And if they take the black color, the baby will become black color. There are some misconceptions. So we have some hospitals, they have more number of deliveries. When you identify why there are more number of deliveries in the hospital, they say they happen to a delivery at that hospital, they will have a male child. The community is having the misconception. So all those things for prematurities, antenatal steroids. So we can PDCA cycle we can do. We can identify the problems we can do. So mainly the neonatal health targets. So we can allow the targets into practical and testable changes in the real-time clinical setting, small changes that can make changes in our clinical setups. So we have identified the gaps. Some for bottlenecks. So there is some equipment problems or sometimes a delayed startage of antibiotics, antibiotic policy in the hospital, first, second, third, they should not use the third. So we can't give a higher antibiotic for all. So first line, second line, third line, four small steps. So national guidelines, you can adapt them to locally in the primary health centers or district level hospitals and also in medical colleges. So generating local evidences, that's a real-time data, what we happen in our setups, we can identify, that can give you a feedback to the policy makers to change for the entire. So then we have a continuous improvement that can be improved for the neonatal outcomes. So and then systematically for the national programs and state programs can give feedback and that's a dynamic adaptations and policy formation the real aim. So thank you very much. So now we are in a phase of quality improvement. So after evidence-based medicine, so we are. Thank you very much.
Thank you so much for this insightful session, sir. With this, we shall break for a short tea break. The tea is being served at the cafeteria. Our team members would guide you towards the cafeteria. And I request everyone to please be back by 12 p.m. Thank you so much. a short tea break. Let's move forward with the technical sessions. नवजात शिशु के जीवन के पहले 28 दिनों में सुरक्षा उनके जीवित रहने और स्वास्थ्य विकास के लिए बहुत महत्वपूर्ण है। नैदानिक सुरक्षा में सुधार समय पर और सटीक रूप से स्वास्थ्य जोखिमों की पहचान करके हानि को रोकने में मदद करता है। इस विषय पर अपने विचार साझा करने के लिए मैं डॉक्टर हरीश कुमार चलानी सर, विशिष्ट वैज्ञानिक, सोसाइटी ऑफ अप्लाइड स्टडीज, नई दिल्ली को आमंत्रित करती हूँ।
Thank you, dear. And first of all, it's an honor for me to be with you all for an important subject. And as it was said in the opening remark, the first 28 days are absolutely crucial. And that's why one of the important, indicator which we take for any country or a state, the development, we see the neonatal mortality. In fact, infant mortality rate, neonatal mortality rate, and the maternal mortality rate are the three key indicators which judge a particular state, district, or even block performance. With this, now I'll be touching in next 20 minutes about how we prevent the harm in the first 28 days of life. And this harm which we see whenever there is a breach in the following of the evidence-based practices, whenever there is a breach, then we land up with the problems. We do have the evidence-based guidelines for most of the interventions in the first 28 days of life. And as we know, the vision is to provide respectful care to the mom and the baby, and there is no harm to the baby. That's our goal. Whichever place the baby is born, whichever country, whichever site, level of the different care, that is our aim. And when we see the safety of the neonate, we don't see just in the first 28 days when the baby is born. In fact, it is the whole continuum. If you see, right once the baby is, even before the conception, right, periconception period, we say, in the womb, what are the challenges, what are the things which can harm the baby? Or once the baby is born and within the facility, either in the right from the birthing site, both the operation theater or in the labor room or in the newborn care units or even in the postnatal ward. The harm can be at any place or even during the transport, intra or inter-facility, both. And some of the things, when everything goes well, the harm is also possible when we have some, unusual practices at the home setting. Of course, when we see the WHO's commitment of Global Patient Safety Action Plan, which was there, and that is up to 2030, which was there. And even when we see way back the Hippocrates, also mentioned we should not cause any harm. Or when you do any research, or when we were taught about the clinical practice, and I remember the first sentence the teacher in the pharmacology said, it is better to know the side effects of the medication first than the effects of the medication. I think these are, some of the important observations. And similarly about the diagnostics, also it is said you must provide or ask for the investigation. It should supplement your clinical judgment. And the implementation of the diagnostics is equally important, right? And now in this era, when we see less importance is onto the clinical assessment than onto the diagnostic. Of course, when we look at the burden, we do have some data from the developed nations, but when we look at the numbers from the low middle income group countries, you must have also seen the meta-analysis which was published in year 2019. There is a significant amount of the problem which exists in the pediatric population. However, if we see in the neonatal population, we don't have the exact information. And there is some data which people have tried to analyze for the medication errors, which is reported as high as 4 to 35 per 1,000 patient days. And it can be even, number can be high, or sometimes it goes unreported. And in the facility, if you see, these are the broad categories which we find: the device related or the environment related in the NICU. And the most important in the newborn period is the medication errors and hospital acquired infections and even the diagnostics also, and the errors which they happen, and the blood safety, another important. So these are some of the things which are said, and we must have seen in the various, reports in the newspaper, in the media, that there had been the cases of burns, baby got electrocuted, or even at the time when the CFL and the other phototherapy units were there, the plexiform sheet which had been there, that got heated up and caused harm to the baby. These reports are there, but what I would say, perhaps these reports are important to convey to the health administration and health system at a large that we have to be very careful about each and every aspect of the safety for these babies. Now, how to ensure that the safe environment should be available for the baby once the baby is in the NICU or in the special newborn care unit at a district level. The most important thing is, if we are, as I was saying, if we are not careful about the evidence-based practices like giving breast milk to the baby, right? If we are indulging into the formula milk, this is basically a non-safety measure, right? So there are many instances where you will find that the care of these babies is compromised and the baby is subjected to the various harms. Even if, as we know, the small and sick babies, they are, significant cause of mortality in the newborn care units. Now, if we see the various activities which are contributing to the mortality, unnecessarily use of the intravenous fluid, right? That is very important actually, and it is causing the hospital-acquired infection. Similarly, we are treating the premature baby, but we are unable to see their eyes. What is happening to the eyes, right? These are all examples, or using the antibiotics without the proper diagnosis of the sepsis. So these are some of the practices you will find which are responsible for the rise in the cases of the unsafe practices. Or similarly, if the babies who are there under the radiant warmer, now probes, they get displaced, and if the monitoring is compromised, the temperature of the baby goes up, the baby gets dehydrated. Chances of hypernatremia or hyperthermia are there. So these are the important aspects which one has to look at it. And of course, there had been some of the interventions which have been there to minimize the side effects or these problems to the root, or even involving the pharmacologist, pharmacotherapist in these cases. It's equally important because a lot of the medication errors which are happening if we do not adhere to uh, uh, the proper protocols. Many of these doses are in micrograms or milligrams, and you all must have seen the errors. They do happen, and we have to be little very careful. So sensitization of the healthcare providers, it is very, very important, and all the healthcare provider, and it is a periodic, sensitization and auditing of each and every episode of the error which happens. If we don't audit, and if we are not careful about that, and if we do not follow the protocol, naturally these errors will be happening and there will be a loss to many lives. Now, one of the things where we can minimize is, as we heard in the morning lecture from Tamil Nadu, that involving the family members, uh, they both, and in our guidelines also, national guidelines, the Lakshya program. Now, we do say that start immediate skin to skin contact in the first 1 hour of. Many of you must have seen the way the delivery table is there. There is hardly any, side rail. It's not possible unless there is some family member there to support the baby. And that's why when we are having now the LDR concept of the delivery tables in such a way, and in the Lakshya program, many of these states are doing very well. And with their performance, and you can initiate those interventions. Early initiation of the breast milk, right? And similarly, early skin-to-skin contact. These are some of the interventions which are quite possible at the birthing place. And similarly, the another concept of the family-centered care, which of course Aarti Maria is here. He would be talking much more on that. These are some of the additional things which are important. Now, when we see the family participated care, the concept came when we see in the nurturing care, most of the components, if you see, the bringing the family members inside so that they can be involved in the care of the baby. And this care, has got several. In fact, it is the monitoring of the baby also, and involving, so that when we say effective kangaroo mother care we provided, or early breast milk is to be given. And currently our practices are the mothers are in the postnatal ward or they are discharged, right? Most of the centers. And you are allowing the mothers intermittently. And some of the places I have seen, NICU, etc., they don't even allow the families. Now, if you want the baby to receive exclusive breast milk feeding, they should have the kangaroo mother care for small babies. How is it possible that they could be separate? So they have to be brought together. And that is the excellent the example of the family-centered care, where you involve the family members to participate in the care of the baby. So that instead of being visitors, they are the actual caregivers. And in fact, a lot of the nursing work, it has been seen is to be is reduced with the involvement of the family members. Now, this is what, if we see the family-centered care, if you see, they can be asked to follow these practices, and they can be involved in the care of these babies. And normally, if you see the culture in the most of the neonatal units, is they are fed every 2 to 3 hours. There is a fixed schedule because one nurse is looking after 6 to 8 or sometimes 10 babies. Here, the mother is there with the baby when she visits most of the time, or he is with the baby 24 hours. He looks at the cues. He changes the diaper. Most of these things are there once the mother is there. But if you want to make sure the mother being the part of the caregiver, just like the Lakshya program, then we have to rethink about the designs of our newborn unit. The places where you have the space, bring the mother's bed inside. Otherwise, allow the mother or family member to visit the newborn unit as often as possible. That's the major change which one has to do it. And even the obstetricians, they have to come inside to take care of the postnatal care of the mother. Because now you are shifting the moms to the NICU area. So that kind of the concept which we are looking at. This is one of the example of the unit which we made it at the Safdarjung Hospital during the period of trial, where it was seen that if you provide the kangaroo mother care immediately after birth, even for sick babies, does it affect the mortality? Because previous WHO guidelines, they said it is to be provided in the facility and that too for stable babies. And I am happy to announce that the latest WHO guidelines will be released on 17th of the November this year. So you will see now the change in the concept, and that gave the birth to the mother newborn care unit. And this is how the each cubicle it looks like, where there is a mother's bed along with the other level 2 care facility. And if you see the advantages of this, as I was saying, all the components of the nurturing care, they are going to be provided. And the previously, when the mother comes only intermittently, the KMC duration was not effective, right? It was less than 8 hours. Now, WHO has identified as a one of the quality indicators that minimum 8 hours should be the kangaroo mother care. So all, if you see the advantages of allowing the mother with the baby, and in fact, when we got this response of this, in fact, our medical superintendent and even the administrator, they said, why not allow the family members, even the adult ICU? If you see most of the time, in the COVID time, we lost many lives because of lack of supportive. And I think here I would say, if we want to bring the quality care for the safety, actually, we have to bring the family member inside. They, in fact, see what is the oxygen saturation, right? They see the IV swelling. They change the diapers. Many of the tasks, in fact, we quantified in one of our PhD students, 60% of the nursing work is reduced by the, presence of the family. And these family members can contribute in all these. And believe me, and we practiced this from 2016, but I know Aarti had been doing it for even much before. The babies are in a comfort zone, more relaxed. Usual, the alarms or the noise of crying in the conventional NICUs is gone actually. And I still remember when we started this concept of keeping the mom and the baby together in the NICU. our mission director's first concern was, will it increase the infection by the presence of the mother? And which is obvious, people they will think. But believe me, there was 18% less infection. And now we have seen sepsis related mortality is much less with the presence of the family member. And the bugs are different, believe me. Immediately the baby is kept onto the mom's chest. It's gram negative are more common in the conventional NICUs and gram positive are more in this mother newborn care. Similarly, once the baby is discharged, the best way is to transport the baby in the KMC position. Now we have got enough data that KMC is a better option. And now we are going for another trial actually, which looks into whether the conventional transport in the incubator versus the transport in the KMC. That is also now in the process and we are going to see the results of that. So all this is important and it is equally important when we see the baby at home level. Baby should be away from any medication except the medications which have been advised from the facility. And most of the babies are advised only the vitamin D and the vitamins. That's all. And they need to continue those. Otherwise, exclusive breast milk feeding, keeping the baby warm. I think these are the critical things and avoiding the all pre-lactals and other things. They are not only the source of infection, but also are not safe for the baby. And before I close, I think if we can summarize that we should adopt the policy of the Lakshya and the family center. This is going to be providing the dividends. And whenever we see we have the equipment which is functional and auditing also. Any equipment which is non-functional for 1 month must be reported actually and must be made sure. Norms for the space are now available with us and also the practicing the evidence-based interventions, safe transport and having the safe actions at the home setting. I think we are now trying to achieve the single digit MMR, but we are still quite far off from that because still our 45% of the districts are not going to reach the single digit MMR by 2030. So this is the time we should start working on the interventions which are evidence-based and we should change our philosophy. And I think this is the last slide, that if we want to have a safe environment and safe actions, we have to start not only from the neonatal period, but right from the periconception period. Thank you, friends. Thank you for the opportunity to be with you all. Thank you. Any questions? If there are, I'd be happy to answer. Thank you, friends.
Thank you so much, sir, for this wonderful session. नवजात शिशुओं और बच्चों में अस्पताल में होने वाले संक्रमण को रोकने, सुरक्षित और सही इलाज के लिए बहुत जरूरी है। संक्रमण रोकने और नियंत्रण के उपाय मजबूत करने से हमारे सबसे कमजोर मरीजों को सुरक्षा सुनिश्चित होती है। इस विषय पर अपना विचार साझा करने के लिए हम डॉक्टर पूर्वा माथुर मैम Professor of Microbiology and Hospital Infection Control Division, Department of Lab Medicine, JPN Apex Trauma Center, AIMS, New Delhi का स्वागत करता हूँ. Over to you.
Everyone, and like to thank MHRC for giving me this opportunity and a very opportune time to talk about healthcare associated infections in children. We often talk about HAIs mostly in the purview of infections encountered in the adult, but we forget that children are a very vulnerable population. So we know that children suffer from infections much more than adults because they have a weakened immune system and they have a higher morbidity, mortality, placement of invasive devices, surgical interventions, and also we know that the profile of children admitted to hospital is changing. We have more severe infections, uh, immunocompromised states, complex surgeries. Also, because a lot of care is now being shifted to ambulatory or home-based care. So the patients or children who are admitted to hospitals are generally more severely ill. That is why they are more vulnerable also. And we know that the goal of infection control is to prevent infection in every child. Now, children can also transmit and harbor infections more than adults. So the gastrointestinal tract and the respiratory tracts of patients who are infected with, for example, respiratory syncytial virus or rotavirus, they are loaded with bacteria. And because bacteria and viruses, and because we do not expect children to practice the usual procedures of infection control, care of their secretions or hand hygiene, there is a lot more chance of cross transmission of infection with children. Also, there is a frequent contact of family members and healthcare workers when there is care of children, changing the diapers or cleaning the nose or respiratory tract. Also, sharing of toys. So there are play areas for example, long-term facilities like cancer care where patients are receiving chemotherapy. So there are common play areas, and children tend to share those toys. These are the sources for cross-transmission of infections. So, infections in children can occur because of invasive diseases per se. They can also be because of devices which are placed and because of therapy. So, patients who are getting repeated surgeries, pediatric surgery population, or hematopoietic bone marrow transplant patient or chemotherapy patients, these have a higher risk of infections like bloodstream infections, urinary tract infections, and now, we know that neonatal ICUs are more prone to get infected than pediatric ICUs, and PICUs are more prone, patients in PICU are more prone to get infected as compared to those in general ward. So, this is one of the seminal study done by the pediatrics, the neonatal unit of AIMS under Dr. V.K. Paul, in which is known as the Dennis study, which was a cohort of 4 hospital, and it was found that this cohort of even outborn newborns had a very high rate of neonatal sepsis caused by gram negatives like Acinetobacter baumannii, which are very, very predominant in adult ICU. And surprisingly, these patients also had a very high incidence of Candida BSc. So this is the state of affairs in the capital city of Delhi, and this was one of the very famously quoted study. Now, another study by the same group found that neonatal sepsis is one of the most common. So more than 50% of deaths in neonatal period is due to sepsis. So again, alarming rates. Now, we are working on a surveillance system across India since 2015, in which more than 7,000 healthcare workers have been trained. Currently, there are more than 100 hospitals which are part of this network being run by All India Institute of Medical Sciences. Our website is haisindia.com, and we have recently trained around 700 district hospitals through NHSRC on HAI surveillance. And we found that from a period of 2017 to 2025, out of the more than 10 lakh patient days in PICO and NICU, the CLABSI rate was 10.3 per thousand central line days, which is much higher than adult ICU. So we had a total of more than 5,552 episodes of bloodstream infections in the PICU and NICU. Most of the organisms were gram negative. So dominance of organism was gram negative. I was happy to hear our previous speaker mentioning that kangaroo mother care, in those patients or those newborns, gram positives are more. If we have more of gram positives, then it's a happy story because gram negatives are notorious to treat. We also found that the most important organisms were Klebsiella followed by Acinetobacter, very notorious multi-drug resistant organisms which are difficult to treat. So they actually are causing a very high burden of bloodstream infections and a very high mortality. So 37.9% of these patients in PICO and NICU had a 14-day fatal outcome. Now, when we come to the urinary tract infections, out of the 501 urinary tract infections, the COTI rate was 2.1 per thousand urinary catheter days. Again, gram negatives predominated, followed by Candida species. And individually, Candida was the most common organism. The outcomes, again, almost 20% of these patients who had a hospital-acquired urinary tract infection had a 14-day fatal outcome. Now, infections in pediatric ICUs or NICU are generally spread by either a direct contact, indirect contact, droplet mechanism, or airborne route by vehicle or vector borne. Now, most frequent of these modes of transmission is through direct contact, which is, by way of hands, and that is why hand hygiene is the most important. And if we actually use standard precautions, then we can control most of these infections which are transmitted through direct contact. There may be additional precautions like gowns and gloves needed in cases where there is severe respiratory illness or there is a rotavirus diarrhea where the healthcare workers or the parents have to change diaper frequently. In those cases, an addition of gloves or gowns may be needed. So if there is a watery diarrhea which is uncontrolled, in those cases, it is advisable to use additional gloves. Droplet transmission is very important in pediatrics because children generally don't have, respiratory etiquettes, which we advise as we have seen in COVID-19 pandemic. Children usually find it difficult to do that. So all these droplets which are expelled, they settle on the surfaces or on the beds or the bed railings. And through that, if the hands are touched, these droplets can be transmitted. So surgical masks are recommended for those within 1 meter of the patient. Now, there are these organisms which are very fragile and they do not survive on environment for hands. These are Haemophilus influenzae, Neisseria, and Bordetella, which causes pertussis. But there are organisms like RSV, influenza, parainfluenza, and rhinoviruses, which survive for a long time, and that is why you need additional precautions to prevent their spread. Airborne infections are these are very small droplets which survive. They don't drop on the surface, and because they are very small in size, they circulate in the air. So they can move in and around the rooms and out of the window, and that is why long-term transmission is very, common in airborne transmission, and therefore you either need a negative pressure room or a HEPA filtered cubicle. Airborne transmission is uncommon, but infections like varicella, measles, and tuberculosis can spread by airborne route, and that is why, and especially children do not spread or secrete so much of Mycobacterium tuberculosis organism. But if the parents are infective, then they are a source of infection in the pediatric ICUs, pediatric wards, and therefore you need special negative pressure chambers or HEPA filtered units to control. Then there are common vehicle transmission like waterborne outbreaks, which can be easily taken care of by safe water, safe food practices. So WASH programs are very important. And then vector-borne diseases like malaria and dengue, which can be again taken care of very well if the hospitals have a good vector-borne disease control program and there is, all the stagnant water and things like that are taken care of. So routine practices like hand hygiene and standard precautions can control most of these infections which occur in PICU and NICU. And we have seen in our surveillance network that uh, all the ICUs, it is the PICU and NICU which are the most maintained because the stakes are so high, the nurse to patient ratio is very, very optimal. The healthcare workers are very compassionate. So it's easy to control them. So standard precautions and hand hygiene, and then you can have gloves and masks, depending on the type of cross transmission. And then you can have special precautions for multi-drug resistant pathogens, which are there as guidelines, which may harbor around contact precautions like use of gloves and uh, hand hygiene with a medicated. Post-exposure prophylaxis is very important, especially for healthcare workers. So, if there is an exposure to varicella, measles, or hepatitis, it is advisable to give post-exposure prophylaxis. And then antibiotic prophylaxis for meningococcus, Haemophilus influenzae, pertussis, and tuberculosis, if there is an infective disease. Then it is also very important that prevention of infection from healthcare workers to children is avoided. So all the healthcare workers must be immunized against DPT, diphtheria, pertussis, tetanus, and polio. Transmission will also occur from children to healthcare workers, and therefore, again, the healthcare workers must be immunized. So, and also transmission can occur from visitors. So, there should be a good policy of controlling visitors to the hospital, especially elder siblings. These children harbor pathogens, so parents and siblings must be advised to have a very restricted visitor policy, and there should be a proper control on visitors to the hospital. Immunocompromised children require special mention because they are susceptible to even common pathogens. So, many of them, like the bone marrow transplant unit, they are susceptible to fungal infections. So, you need special HEPA filtered units and also proper immunization. So, to prevent fungal infections. Now, these are some of the recommendations. I took it from the SHIA. It's a guideline for 2022 for prevention of CLABSI in neonatal ICU. So there are 14 pertinent questions which need to be answered. So does the use of non-sterile gloves after hand hygiene prevent CLABSI? So the recommendation is no. Does the use of one central line type with another prevent CLABSI infection? So you can choose the central line depending on the purpose, not depending on whether it reduces infection or not. So you can actually choose a subclavian line if it is better for administration and it reduces the infection better. Does the use of one central line insertion site is better than the other site? So again, you have to choose the insertion line site depending on the purpose of why you are using the central line, not because you have to reduce infection. Does the use of single lumen catheter, is it better than the multi-lumen catheter? So it is better to use a single lumen catheter than multiple lumen catheter. Then consider the use of alcohol containing chlorhexidine, but one has to take into consideration the gestational age of the patient because chlorhexidine has adverse effects in severely premature newborns. So you have to, of course, it is better, but you have to consider gestational age. Does chlorhexidine bathing compared with no bathing or placebo prevent infection in NICU? So there is a conditional recommendation that consider the use of chlorhexidine bathing, again based on the gestational age of the patient. Then one has to minimize the number of central line herbs because the more the number of central line herbs, the more are the chances of infection. Then one has to consider central line antimicrobial impregnated central lines in addition to other infection prevention practices because it reduces the CLABSI rate. Then what is the optimum duration of umbilical artery and umbilical venous catheter? is generally 7 days. Beyond that, one has to consider if you have to increase the duration of catheterization, it is a conditional recommendation. Then what is the optimal duration of a peripherally inserted central line days? Again, if there ideally it should be removed as soon as possible, but if there is a need, one can increase it depending on the pros and cons of infection. Then does the use of a dedicated catheter care team provide better care? Again, there is a conditional recommendation. So it is advisable to have a dedicated team provided you have the necessary manpower. What are the optimal elements of central line insertion? So the bundled intervention is better. The bundle is a set of 4 or 5 preventive strategies. So when you apply it together, there is a better chance of reduction of CLABSI rate. Then what is the efficacy of prophylactic antimicrobials? And the recommendation is not to use any prophylactic antimicrobial treatment. And finally, what is the efficacy of prophylactic anticoagulant for prevention of CLABSI? Again, the recommendation is not to use any prophylactic antibiotic. Then finally, coming to the prevention of VAP or VAE, the essential practice is to avoid ventilation because the more you use ventilators, the higher the chances of infection. Then minimize the duration of mechanical ventilation. So the only high quality evidence for prevention of VAP is use caffeine therapy for apnea of prematurity within 72 hours after birth, facilitate extubation. All the other evidences which were previously there in the previous guidelines have been now shown to have low quality of life. What are the additional approaches for preterm neonates? Lateral recumbent position, reverse, Wendelberg position, closed or inline sectioning, and oral care with maternal colostrum. Again, all of them have low quality of evidence except with the maternal care, oral care with maternal colostrum. Approaches that are generally not recommended are regular oral care with antiseptics, H2 blockers, that is acidity prevention, prophylactic broad spectrum antibiotics, and spontaneous radiotrials. They again have low or moderate quality of evidence. Then approaches that are not applicable to preterm infants are daily interruption of sedation, prophylactic antibiotics and symbiotics, endotracheal tubes equipped with subglottic section drains, and silver-coated endotracheal tubes. So these are practices that should not be used in preterm neonates, but they are used in adult ICUs. Then what are the essential practices for pediatric patients? Avoid intubation if possible and use non-invasive intubation as far as so minimize the duration of intubation. So you have to assess the readiness to extubate as soon as possible. Take steps to minimize unplanned extubations, avoid fluid overload, provide regular oral care, and elevate the head end of the bed. Then maintaining the ventilator circuits, you have to change the ventilator circuits and maintain them as per manufacturer's instructions. Remove the condensate from ventilator circuits frequently, and then use appropriate endotracheal settings depending on the severity of the pediatric patient. Then what are the additional approaches for pediatric patient? Minimize sedation, use endotracheal tubes with subglottic suctioning drainage board, and consider earlier tracheostomy. Approaches that are not generally recommended for pediatric patients are prolonged systemic antibiotic treatment, selective oral oropharyngeal or digestive decontamination, and prophylactic probiotics. And the practices which have no impact on VAC rate are oral care with chlorhexidine and stress ulcer prophylaxis. And what are the practices which lower the VAP rate but may not have any impact on the length of stay or mortality is silver-coated endotracheal tubes. So these are some of the references. Mainly these are from the GITSA guidelines and the national guidelines for infection control. So once again, I would like to thank NHSRC for taking up this important topic and for this opportunity.
Thank you so much, ma'am. Empowering parents and caregivers is central to advancing patient safety. Goal 1 focuses on actively engaging children and families as partners in care to ensure safer, more effective, and compassionate healthcare. To enrich our understanding of this topic, please join me in welcoming Dr. Aarti Maria Ma'am, Dean and Professor, RML Hospital. Over to you, ma'am.
Namaste, everybody. Namaste. So, good afternoon, and I am going to talk about. So, you'll wonder parent empowering and safety. Are they related? Does anybody have a doubt? I could be the devil's advocate and I could say yes. Because once I went to the one SNCO, I,
1980s. Structures are wonderful. Is there any issue? Structure is not important. No. Quality is possibly there is an issue. So regular calls in the Spanish, and even we get a complex steps. Will we share my bed? We are having not so good looking nurseries. So all that appears good, this has to be. Quality of care has to be. Once you're stressing, then still you must see no, I know. Sometimes it's serious. Well, it's not some- no. Smaller. So, better self-control, knowledge and skills. Skills. Strict system. Environments. Shape. Virus. I mean, anxieties, anxiety, hoping we can maybe gain more protection, guidance, and support. Therefore, there is not a team practice.
How you created the winning machines. So, is started using for this system. That's not we wanted when we start out there was
In family-centered care, we impart essential caregiving skills to mothers and parent attendants for care of their sick newborn throughout the hospitalization.
Good afternoon, everyone. It is an honor to welcome our esteemed dignitaries who have graced this occasion with their presence. I would like to welcome Ms. Aradhna Patnaik, ma'am, Additional Secretary and Mission Director, Ministry of Health and Family Welfare, Government of India. Dr. Rajiv Patni, sir, Advisor, Quality Patient Safety Division, NHSRC.
His Jain, sir, Joint Secretary Policy, Ministry of Health and Family Welfare. Dr. Saroj Kumar, sir, Director, Ministry of Health and Family Welfare, Government of India. हम अपने साथ प्रगतिशील पूर्व विभाग का पालन महसूस कर रहे हैं। So उन्होंने स्वास्थ्य देखभाल नीतियों प्रभाव को हर नीति में महत्वपूर्ण है। मैं सभी सम्मानित अतिथियों से अनुरोध करती हूँ कि मैं आगे आकर टीम प्रोत्साहित करूँ।
I would request Dr. Rajiv Patni, sir, Advisor, Quality and Patient Safety Division, NHSRC, please deliver the opening remark and objective of today's event. Over to you, sir.
A very good morning once again to all of you. The day is developing beautifully, and we've had some lovely deliberations till now. At the very outset, I extend a warm welcome to Srimati Aradhna Patnaik, Additional Secretary, Mission Director, National Health Mission, Ministry of Health and Family Welfare, Government of India. Ma'am, we are honored to have you amongst us today. You have been leading the quality initiative across the country, and the quality and patient safety movement has received an immense impetus through your initiatives. I extend a warm welcome to all the participants from the states. Ma'am, we have participants from 22 states, 71 participants are representing their states. You are the people who are taking the quality movement forward. So we salute you, and we will look forward to engaging with you as we go through this. We also have participants presenting various development partners, academic institutions, and organizations that are working on the field in patient safety and quality improvement, and also in the field of child and neonatal. We started the program this morning by laying the text. The theme for the quality patient safety this year is, for the World Patient Safety Day this year is safe care for every newborn and every child. The slogan patient safety from the start. And it is normally planned on 17th of September globally. This year, I think it was serendipitous. We were lucky that it all started with Swasthmari program, because a healthy childhood begins with a healthy mother, with a Swasthmari, and with a healthy family. So we will look forward to your inputs on how it has panned out. We have 5 themes, and in the 5 goals in the patient safety day, and we have domain experts who will be speaking about each one of them. The first goal is engaging children, parents, and families. Second is medication safety. Third is diagnostic safety. Fourth is preventing healthcare associated infections. And the final one is reduce risks for small and sick. In the morning, we had findings from the Sakushal initiative from the states. This is the 3rd year we are doing it. And the trends that we're getting are very, very encouraging. There has been incremental growth in the median findings. And another very encouraging input is that the NQAS certified facilities have a much higher patient safety score. So median score for NQAS certified facilities is 80, which I think is very encouraging. Ma'am, as you had directed us, we are working towards impact assessment, NQAS, and the various other programs. Yes. Thereafter, we had presentations from the states. This is a platform for cross-learning and best practices which are there. So we heard from the state of Karnataka. We also heard from state of Andhra Pradesh, and we had the findings come in. The tea time, the energy and engagement with all the participants, very nice, and we did exchange notes about what was being presented here. Going forwards, ma'am, we have the various presentations from the domain experts, tools which are there. And while we await the guests, I'd like to just bring on board the fact that 41,000 facilities are now in process. Now, 41,000 is only 24% of the total healthcare facilities. So we need to step up our game. We have been working on how to strategize this thing. With your permission now, we will discuss that on a suitable. NQuas already incorporates all the elements which are required towards promoting child and newborn care. There are more that can be added in the patient safety side, but we already have these, and we also have focused programs, STAN and Lakshya. Sakushal, of course, is towards patient safety. In the last year, we've had additional elements added to the NQuas frameworks. IPHL guidelines were launched from the and the first two facilities which came forward for IPHL have been assessed. Plus, the others are also following through, and there's a few of facilities which want this. I think the PM Abhi workshop that we had in Chennai. The next one is the critical care groups. We are working towards them. We are also working towards the standards for medical college hospitals. That will be for the respective meetings. First round is over. We are going to have first. This year, ma'am, under your leadership, the healthcare-associated infection guidelines, surveillance reporting were released. I'm happy to share we have given a copy of that to all the participants so that we hit the ground running, we jump started, and as we have the dissemination and roll out, we have the facilities. This year, Sakushal inputs which came, we got inputs from 502 district hospitals, plus another 300 SDHs. And I've already shared the findings. I'm under your guidance and leadership, under your with your directions. The team has been highly motivated, and we've been moving forward together. But I think credit should be also given to the states who have been implementing your directions on the ground. Healthcare quality cannot move in silos. We have to work together, and we look forward to your guidance and directions, ma'am, and motivating words for how to take the all the facilities to 100% NQuas certificates. I'll pause here, ma'am, and we'll forward to hearing.
session with Rwanda and 12 sessions wherein we have with us Dr. Shobana Gupta ma'am will talk about New Harlem World Child Health Services. Followed by there will be a session by Dr. Shobana Gupta who will talk about safe pediatric medication practices. That is our goal to enhance communication. Followed by that, we'll have three closing sessions.
It's an honor to welcome our guest of honor, Shri Saurabh Jain, Sir, Joint Secretary Policy, Ministry of Health and Family Welfare, Government of India.
हम अपने साथ प्रदर्शन अवधियों मानव महसूस कर रहे हैं जिन्होंने एक बार नहीं किया और प्रभाव प्रकार दे दो प्रमुखों को बैठ पाए मैं सभी सम्मानित अतिथियों से अनुरोध करती हूं कि वे आगे आकर दीप प्रज्वलित करें
With this, I would request Ms. Nasreen ma'am to please welcome Ms. Aradhna Patnaik ma'am, Additional Secretary and Mission Director, Ministry of Health and Family Welfare, with the plant and a patient safety badge. Since ma'am has taken responsibility, NCOA certifications has increased exponentially from 6,000 to more than 40,000. Under her guidance, virtual assessment of Ayushman Arogya Mandir Sub-Health Center, integrated public health laboratories, the revision of Kayakalp initiatives and launch of HAI surveillance and reporting guidelines for district-level health facilities have been rolled out successfully. Her dedicated efforts and strategic vision has significantly contributed in strengthening the healthcare system. We are honored to have you, ma'am.
I would now like to invite Ms. Rachna ma'am to extend warm welcome to Shri Saurabh Jain, sir, Joint Secretary Policy, Ministry of Health and Family Welfare, Government of India, with a plan and patient safety badge. Parliamentary विकास सूचना प्रौद्योगिकी शिक्षण और स्वास्थ्य जैसे विकल्प निर्मित सुधार की उपाय दिखाएंगे राष्ट्रीय स्वास्थ्य मिशन और आयुष्मान भारत जैसी पहलों के तहत उन्होंने स्वास्थ्य प्रणाली को सुदृढ़ किया और पारदर्शिता और जवाबदेही को बढ़ावा दिया है। सर, हम आपका ससम्मान समझते हैं।
Now, I would request Ms. Riya to please welcome Dr. Rajiv Patni, sir, Advisor, Quality and Patient Safety Division, NHSRC, with a plan and a patient safety badge.
Sir, भारतीय वायुसेना अनुभवी सदस्य हैं। प्रसारण का कॉन्फिडेंशियल डेवलपमेंट के प्रोफेशनल एवं 19 साल से गुणवत्ता रिपोर्ट। सर, एक सक्रिय शिक्षावाद और जर्नल ऑफ हेल्थकेयर मैनेजमेंट स्टैंडर्ड से संपादित किए गोल प्लेस है। सर, हम आपका सम्मान करते हैं।
Now, I would like to invite Sri Saurabh Jain, sir, Joint Secretary Policy, Ministry of Health and Family Welfare, Government of India, to address our distinguished guests. Over to you, sir.
Good afternoon, everyone. Respected Secretary and Mission Director. Rajiv Patni, Advisor Policy, representatives of various state governments and partners, academic institutions, experts, and dear friends. It's an immense pleasure to be among all of you for this World Patient Safety Day, which is being organized all across the country. This year's theme is Safe Care for Every Newborn and Every Child. This theme reminds us that safety starts in the first breath of life. Every mother who walks into the hospital does so with only one hope, that once she returns back, herself and her child is safe. Ensuring that is our collective responsibility. Patient safety is not only a slogan, it is our commitment and foundation of trust in the healthcare facilities. When one error which is preventable, whether it is a wrong dose, the infection control practices, or a delayed referral, can undo the months of progress. For a mother or a newborn, these moments are life-changing, and for us, this is a call to do better every single day. The Ministry of Health and Family Welfare has, over the years, embedded safety as the essential part of quality. Through the National Patient Safety Implementation Framework, the ministry has guided the states to integrate safety in their healthcare facilities and across various programs. We have built a strong ecosystem of various initiatives regarding patient safety and quality. We have the Kayak initiatives, that is for cleanliness and infection control, Lakshya for safe and maternity, respectful maternity care, Muskan for child-friendly services, Mera Aspatal for ensuring that we receive the patient feedback and ensuring the accountability in our public health services, and National Quality Assurance Standards for institutionalizing the quality aspects in all our provisioning of healthcare services. Together, these services have brought tremendous change in how the healthcare is delivered, to cleaner facilities, better infection control, safer systems. So far, under these initiatives, more than 20,000 healthcare facilities have been certified. Our goal is very ambitious. We want that all the healthcare facilities should be certified by December 2026. And this commitment reflects our belief and that quality and safety are not just privileges, but they are the rights of every citizen, irrespective of where they are living or from which strata of society they are coming from. To strengthen this culture of safety, the ministry through the NHSRC has developed a social platform. It is a self-assessment tool for ensuring that the gaps are addressed and the facilities can be benchmarked. Helps hospitals to identify their strengths, identify the gaps, and track improvements in real time. Together, they will also see the discussions on the digital NQA certificate, which gives the commitment of a commitment on transparent and data-driven systems for ensuring healthcare safety. This year's focus on newborn and child care safety is especially relevant because, as we all know, the first 28 days in a child's life is very, very critical. And the small lapses at this stage can have
lifelong consequences. Complications during childbirth, medication doses, unsafe or infections can endanger the lives that have just begun. By focusing on safe childbirth, proper infection control, and communication with mothers, we not only save lives, but we develop the trust of our families into the public healthcare systems. This workshop is a platform for action. Over the next few hours, you will be discussing about the various ways in which the patient safety can be strengthened, how to ensure that our hospitals are prevented from infections and medication errors. I will urge all of you to discuss among yourself, learn from each other, and once you go back, take with yourself one or two best practices that you can implement in your respective healthcare systems. I will also urge you to do two specific directions that once you go back to implement in your respective healthcare facilities. As I have already explained, the ministry's ambitious target of ensuring NQAS facilities, NQAS certified facilities in all the healthcare institutions by December 2026. So we need support from all of you to make this happen, and also to complete the self-assessment through this official platform, so that all your gaps can be identified and you can chalk out the various action plan for ensuring that these gaps can be addressed. These steps will not only improve our healthcare facilities, but will also ensure that they are much safer facilities across the country. I would like to compliment the efforts of all of you, the NHRC and all the nodal officers who have been assembled here. You are doing a very great service in ensuring quality healthcare that is being delivered across the healthcare facilities. Your commitment has ensured that it is not only a slogan, but it is a national movement now. So let us utilize this patient safety day to renew our commitment once again that no mother or child should suffer because of preventable harm in our healthcare facilities. Let us ensure that every birth is safe, every procedure is done with care, every patient returns home healthier and happier than when they come, and also builds a trust. They are much more, have more trust in the public healthcare facilities. I would like to thank all of you, and I wish this workshop very resounding success. Thank you very much.
Thank you so much, sir. With profound respect, I now request Ms. Aradhna Patnaik, ma'am, Additional Secretary and Mission Director, Ministry of Health and Family Welfare, Government of India, to deliver her address to our valued guests. Over to you.
Good afternoon to all of you, and a warm welcome to all of you again for this conference. In fact, I was supposed to attend from 10 o'clock in the morning, but there was suddenly another meeting which myself and Joint Secretary Saurav, we had to attend, which Secretary was chairing. So that's why we got this inaugural part. It was postponed to 1 p.m. So as Dr. Rajiv has already mentioned that a lot of presentations have already happened in the first half. All the states have presented and some experts have already deliberated, and the further sessions are in the second half. So as you are aware of the topic on which we are discussing, just initially to start the discussions, I would just give you just a few figures. All of you must be aware, but we need to really ponder upon those figures. We are actually targeting the child and the mother. If you want to have a safe child and a safe newborn, and also a safe mother, because if the child is safe, if the mother is safe, then only the child will be safe. So for regarding MMR, IMR, under 5 mortality rates, you all know we have done a lot of remarkable achievement at the international level, even global level. If we compare the reduction, our rates are much higher, more than double the global reduction. There are more than 86% reduction in MMR, more than 75% reduction in under 5 mortality. But there are still figures which haunt us. Those figures, I will say, if you all, I don't know whether you're aware or not, more than 73% of neonatal deaths happen within first week of delivery. More than 2/3 of maternal deaths happen within first week of delivery. More than almost 55% maternal deaths happen within first 48 hours. And more than 50%, almost 50% neonatal deaths happen within first 48 hours. So we need to actually address that problem now. If we go back 15 years down the line, 20 years down the line, when NHM had just started, taking shape, at that time we were struggling with, home deliveries happening. Most of the deliveries are happening at home, so JSY came to promote institutional delivery. Now more than 99% of the deliveries are happening in institutions. Then the challenges came of deaths happening during transit from home to the hospital. So for that, JSSK came, various states experimented. I remember during my days at MDNHM, we started the Mamta Vahan, which was basically to bring the pregnant women to the hospital in time so that institutional delivery also happens and the mother is in safe hands. So all these interventions which started time, and then we had the home-based newborn care. So all those things have added on, and because of that only our maternal deaths have reduced drastically and neonatal deaths have reduced drastically. Now deaths are not happening at home or during transit. Now most of the deaths are happening after reaching the facility, after the delivery. So how do we address that? That is the biggest challenge today. Even providing all the services timely to the pregnant women and to the child, yet deaths are happening. So somehow quality is now the prime issue for us. Quality care. The mother has reached the hospital, but did she receive quality care at the health facility where she was referred to? Same applies to the child. So now quality care has to be our most important target, the goal. So that's why I have been also putting all the states and all the our teams. We have increased the experts team. We have increased the external assessors team. Because of that only, I think since now our focus is more on quality care in the last 1 year, we have made a quantum jump also. We were hardly at 10,000 facilities being quality certified, and now we are at more than 40,000, 41,000 as Dr. Patni was saying. So 41,000 facilities already NQAS certified, yet we have a long way. We have 2 lakh health facilities to be NQAS certified. In the field, wherever you travel, all of you from the states, you also know, there's a stark difference between an NQAS certified facility and a normal facility. If we aim to provide this quality service in all the 2 lakh health facilities, then there would be a further drastic reduction in MMR as well as under the NMR. So this is where now our focus has to be. All of you, when you go back, especially representatives from the states, there are states who are doing very well, but there are still states who have to yet to pick up. From last year, we made this also conditionality for release of funds. Unless you go ahead in NQAS certification, we would not release funds. That had a very good impact. I didn't want to do it, but since NQAS was not being focused upon, all programs are very important. All of you know there's so many programs you have to look after. Quality is the core. Or if we actually want to provide good service to all the citizens of the country, and we want to reduce MMR and NMR, then we have to focus on quality care. And some of you who have already attended my other programs, I'll again repeat, even if you have heard it, but I'll again repeat why we always focus on the core maternal and child health. We have so many programs. There are many programs under NHM, communicable diseases, non-communicable diseases. We focus on prevention, promotion of in all these. But RCH always remains at the core of all programs. Why? Because it is not a disease. It is a normal biological process. The mother delivers a child. It is basically a new generation coming. The mother is giving a new life, which is a new generation coming in the society. So the next generation's health depends on the health of the mother. That's why on 17th we launched the Swasth Nari Shashakt Parivar Abhiyan. which was main focus was if the mother is healthy, then only she'll be able to give birth to a healthy child, be it a boy or a girl. Then the child will further become a healthy citizen of the country. So Swasth Nari Shashakt Parivar, the family will be healthy only if the mother is healthy, only if the woman of the family is healthy. Be it an adolescent girl, because as she enters puberty, she will then further, once she attains the marriageable age, she gets married and she becomes a mother. She gives birth to a new child. So this entire cycle, why we need to focus upon? Because for others, whenever anyone reaches a hospital, we never want to go to a hospital. I remember only going to hospital to deliver a child. So no one wants to go to a hospital. It is only when someone has a disease, someone has a problem, then you go and get admitted in the hospital. For a diseased person, the family always has two things in mind. बच के आ सकता है, नहीं बच के आ सकता है. If it is a very fatal disease, तो पता नहीं जिंदा रहेंगे. So everyone family knows, they are already preparing themselves. Everyone hopes that the person comes back live. There's always a fear that the person may die because of the illness. But when a mother goes to the hospital, I know all of you from the Indian families, there's so much of celebration happening at the family level itself, in the home, and everyone is expecting that one is going and two will come back. And just imagine if neither of them comes back or only one returns. Either the mother dies, the child returns, the child dies, the mother returns, or not, both of them. So the same, the environment which was happy in the family becomes a sorrowful event, which actually we can prevent. So that's why this is the core of health. So we need to ensure that the mother is given all the services, quality services through her ANC, delivery, post-delivery care, postpartum care, and also for the child. As soon as the child is born, the care for the child, and then further till the child, if has any complications, if it is a low birth baby, then we need to take further care. If there's any neurological development delays happening, again you have to take care. So all those things can happen only if we focus on quality care. So that is why quality patient safety is the prime. That's the most important thing for all of us who are providing services in the field. So that is what I would request all of you to delve upon. How do we further improve patient safety norms or our quality service norms? What all things, where are the faults happening? Why these deaths are happening within 48 hours? Why these deaths are happening, both of the mother and the child, within a week? Somewhere quality is being compromised. This is where we need to focus on. That's why Muskaan and Laksh was focused upon. Now it is becoming an integral part of NCOS. Now I have visited facilities which are NCOS certified, but yet not Muskaan certified. Now that will not happen. NCOS certification only will be given once the labor room as well as the pediatric unit is both the Laksh certification and Muskaan certification is done. So that through that only we'll be able to actually provide quality services. So my best wishes to all of you. I'm sure all of you are now working hard to get your facilities certified. In the end, another word of caution: there are a lot of state certified NCOS facilities, but they are not getting national certification. So don't be in a hurry to just, fill the paper and just give the certificate. Even the state certification should be very rigid as the national certification happens. So all those facilities which are already state certified should apply for national certification within 3 months. Those facilities which have got conditional certification, again for them within 3 months you are some just below the requirement. So if you just address those gaps, you can definitely get national certification. So that is what, and those which are nationally certified, again there are some who are getting derailed. So you have to maintain that. That is another challenge for you. At times it happens there's a very good medical officer there taking the lead, got the facility certified. The medical officer got transferred, again the NCOS certification got derailed. So that again is not a good example. It should be an institutional mechanism, not a single person's effort. So that is where you have to work as a team and ensure even if the head changes, the system continues and the quality certification, the standards they are adhered to, and you maintain that quality certification. So with these words, I would like to thank all of you, Dr. Patni and the entire NHSRC team for organizing this program. And I'm sure all the experts will delve upon the issues which still remain and how do we address them and ensure that all our facilities become NCO certified. That is our goal also till December 26. We have to ensure that all our facilities are NCO certified. And till this December, we had targeted, I think, more than 50,000 or 75,000 was the target. So that also we have to achieve. We are at 41,000. So remaining 25,000, 35,000 we have to focus on in these next 3 months. And I'm sure all of you will work towards ensuring that we reach that target. And by next year end, we have around 1 year, 3 months left to ensure all our 2 lakh health facilities are certified. My best wishes are to all of you. Thank you.
Thank you so much, ma'am. Now, I would request Ms. Aradhna Patnaik, ma'am, Additional Secretary and Mission Director, Ministry of Health and Family Welfare, Government of India, to please administer Patient Safety Pledge with one and all present here and to the nationwide remotely.
शपथ ग्रहण समारोह आरंभ
Of their sick baby.
शपथ लेंगे तो उसके बाद इंग्लिश में हो आप सबसे निवेदन है कि आप अपने स्थानों पर खड़े होकर प्रमाणिक काम ताकि करना ये है we have to pledge आप सब अपना दायां हाथ आगे करके उच्चारण से शुरुआत करें बनाने की स्वयं को सम्मानित करती पता निर्णय लेकर भारत आजाद और जिसमें करेगी प्रयोग को कम करने के उपायों की पहचान बच्चों माता पिता और परिवारों देखभाल में सक्रिय भागीदार एवं सहयोगी के रूप में सशक्त बनाओ उनकी सुरक्षा से संबंधित सभी विषयों में कौशल और दक्षता को निरंतर बढ़ाओ सुरक्षा के बारे में सामूहिक जागरूकता बढ़ाओ सामूहिक सहयोग के माध्यम से सेवाओं में पाठशाला का संगठन एवं प्रचार कर रोगियों के हितों की सुरक्षा हेतु से सीख लेकर सुधार कर सुरक्षा को बढ़ावा देने के हमें सहयोग के द्वारा किए गए प्रयासों का समीक्षा कर Thank you so much, ma'am. I request everyone to please settle down.
A significant step towards efficiency and transparency, the Ministry of Health and Family Welfare has initiated the digitalization of NPOA certificates through the Saksham portal. Earlier, the manual process of certificate issuance took nearly 3 to 6 months, involving multiple stages such as printing, manual completion, signatures, framing, and dispatch. With the new digital system, certificates will now be instantly generated and available within 24 hours of approval, ensuring timely recognition of quality performance. This move not only promotes paperless governance in line with National Digital Health Mission, but also saves time, resources, and enhances accessibility for health facilities across the country.
We have the honor to request Ms. Aradhana Ratnayaka to please inaugurate the NPOA digital center. For receiving the NPOA certification and being awarded the first ever digital NPOA certificate. Thank you so much, ma'am. With this, I request for an order please assemble at the main entrance of the auditorium for the wrap followed by the lunch. The lunch is being served at the cafeteria. I request my team members to please guide everyone towards the main entrance. Someone please come forward. I request everyone to please come forward. Please don't leave the hall.
I request everyone to please settle down. I request everyone to please settle down. Request everyone to please settle down. I welcome you all back again from the lunch. I hope you had a nice time and the food must be up to your expectations. So moving forward with the technical sessions, I would request Dr. Aarti Maria ma'am, Dean and Professor RML Hospital, to please deliver her session on empowering parents and caregivers in patient safety. Over to you, ma'am. I knew after lunch, half the people would have gone. Never mind. So we'll start with this. So this is to show you just a 2-minute video to show you what parent day in our nursery has. The role and position of a partner in care, not a aid or a assistant. So that's a respectful, collaborative partnership of care. उसकी आवाज नहीं आ रही है. So we developed audio-visual training modules for the first time in the world for family parents, for families.
In family-centered care, we impart essential caregiving skills to mothers and parent attendants for care of their sick newborn throughout the hospitalization of their sick baby.
The second one, entry protocol, including hand washing, gowning, and everything, and for that, we need to make provisions also. We made a locker for the parents, then we have made a chappals provision for them, etc., etc. So lots of things. And then we have, and then second module is about activities of daily living, how to, because mother gets into the nursery now, how she gets acclimatized. It can be overwhelming, that experience of the nursery, so many equipment, baby sick, tubes, lines, this, that. So how she gets acclimatized, and then how she is involved in the daily care activities like cleaning a soft baby or breast milk expression or feeding the baby, only feeding, and then about engaging with the baby for developmentally supportive care. And the third video audio module is about the kangaroo mother care, which is for a small set of babies who are no birth weight. Fourth one is preparing them for discharge. So all what they need to know at discharge to hold a continuum of linkage from hospital to home. So that kind of a involvement is there. I think I'll skip it if you had some view of it. Basically to say that
in family-centered care,
collaborative partners of care. Now, can somebody tell me what would be, is it simple to
in
do?
family-centered care, We impart essential caregiving skills to mothers and parent attendants
but it is
for care
most
of their sick
difficult to
newborn
implement.
throughout the
What
hospitalization
seems
of their
simple,
sick baby.
breastfeeding so simple, but so difficult to implement. Then you look at hand hygiene. So simple, what is not nothing. She doesn't understand what but understand when you're to understand what this is the way we implement from admissions and discharge. So you can see this is the way continuous support and supervision. Continuous support and supervision by the healthcare provider is needed. There's a commitment needed from them. And unless that buy-in is there from us, nothing can change to the mothers. Who is committed and why should we be? In fact, the challenge must be providing so happy. I struggle with it. I thought the first family person when you come and she's have relationship she knows hands up. But if I had to daily she knows I'm spending very hard for her. So that is like it's a same question lines. This is the shape of this is not a station. And the person in this world is just work sharing is there. You are going to have the free it's not instructive in a situation like this because station of ownership. So they develop competencies. Once they develop competencies, she is no longer diagnostic. Like this, she is. And I have seen community that are nice with hand washing in the doctor also because now they are careful that the nurse, the mother is watching them. The mother's status in the family, very mother-in-law, what zero, but even you have now, we got choose for a mom. Do you want to step that off with this one? Honestly, one is because what is inspiring to. The other was the other I can see what the other knows and who I do. And the mind with gravity.
Second one was for 3 months. Whenever he was to the hospital on my mother. We were home. First, they were but I want to have the salad and cheese. The spiral is that nine must be that the feeding floor must be through that. Because if you're never trying to get a forest, still, but this will not right. I doctor. My mother was still standing there, so she comes up to me, just asks me, which is yours. Not me. They maybe like this, like maybe this like about me. So that was the tough for me to fix. It's not just asking for higher details, but that is not important. That is I think it's a mindset, it's a concept that aims to develop and nurture habits in partnership. Now we talk, you guys are correct. That's a better market groups. What's this group? Now, all this is very famous. That's I love like the showing going to the part after the videos. And when it is the start out. We are very in having numerous 3 minutes thinking about I haven't seen near video. This will out of the 900 kinds of first and mistakes. One of the business material developed by national religion. And now some law. And they see ones how others have been playing how have been done sort of thinking of those this was now one of years ago. There have been receiving the assessment of all the possible advances, I was just that the question is in one of the factors of sure. You need a strong leadership, you need mindset, you need leader thinking. Universe one, I don't think the one. I'm told something. Starting and this is all our papers, lot of papers have published. Still get them. And of course, so even mothers need from the and they were even saying they will not solve anything. And then you have seen all the steps that was for service from the woman. Actually, right? Actually, so there's a quality, what's the measure of quality? Zero. So one, don't agree. I always get none. Here, I'm reading. It's already okay. And you see some diagram. Darkness. You have advantages where the other is the right. It's for more pricing. It's really Now, just the way now some is not organic. Yes, naturally, we should work. That's the now also the region of work. And it's right from here. And it such work from see. It will see that is never lunch. We custodians of disease. And the paragraph. You want to keep managing how Japan. People you responsible for the parliament of the people is required. First, you need to educate and make sure how to do it. Even the people understand now, just students 15 years of people consider. Now this is once again a ball of glass. We need to run system. The first bias of new one. See how we need something. So this is experiments that have learned some running means culture of plan with the stacks of life workers. Many all that from one is no policy by the population. One please one in the guys, one was number one done all of this time. You got to tell that is the time was perfect. Second, right. So, and we are the one who is special. It's not really that nice. That's now we have confidence of being in then we can going to make a further then not survive for that. Confidence are here. Still they are neither on their way. But still as people are talking strong and right. Vision. Vision. What that was the models that imagine was having feelings. Yes, have feelings. You are mental. Experiences make them negative maximum positive experience.
The mother's womb offers the safest environment for a developing fetus until full-term birth. During the last trimester,
Because when they studies, now just going from that part of then if you see that they have heard of that. This is one.
the mother's womb offers the safe
Instrument is your supply. This is because
The mother's womb offers the safest environment for a developing fetus until full-term birth. During the last trimester and early months after birth, the baby's brain develops rapidly. This period is very sensitive to experiences. Positive experiences such as being in constant touch with her mother in the soothing environment of womb, floating and sleeping in amniotic fluid, play a vital role in promoting normal brain development. However, when a baby is born preterm, small or sick, she must complete this important remaining part of her brain development in the neonatal care unit. During this sensitive period, every single interaction and experience to the preterm matters, as hundreds of interconnections are being formed in the brain every second. Being in the neonatal unit separated from her mother, preterm is exposed to sickness, pain and disturbed sleep in a noisy, bright, and unfriendly environment. These negative experiences affect the structure and function of the developing brains such that long-term learning, behavioral or cognitive problems are common among babies born preterm. The good news is that we can protect the preterm brain from the damaging effects of negative experiences and harsh environment. The developing brain has a unique property of neuroplasticity, that is, ability to reorganize and adapt in response to negative sensory inputs and allowing it potential for recovery. Hence, we caregivers at all times must try to create a soothing and secure environment mimicking the nurturing environment of womb. Since parents best understand the baby and can fulfill her emotional and developmental needs, their active involvement in care, that is, family-centered care, is the best positive experience for any small or sick baby. Whether it is a diaper change, physical touch, hearing mother's voice, or experiencing her smell, every such positive interaction of the baby with her mother and the way she responds is constantly shaping the way her brain is developing. Thus, being constantly mindful of making every interaction with these small and sick newborns a soothing one, in partnership with parents, we can certainly positively shape the brain development of preterm babies. Parents giving birth to a premature baby often suffer from guilt, fear, anxiety, depression, or stress. The compromised state of mother's mental health during pregnancy and after birth also alters the structure of developing brain and contributes to adverse neurodevelopmental outcomes for these babies. Therefore, ensuring physical and emotional comfort of mothers is an integral part of caring for small and sick newborns. WHO and partners have developed a nurturing.
So, can you see, for a small and sick newborn, you need family-centered care, and at the facility, you can have nurturing care through learned competencies, involvement of the parents and healthcare provider wanting to deliver these small elements of care. And at community, we need empowerment. And only then we can optimize early childhood development. Yes, mother, skills you develop that videos or you visual launching their videos. That you see the kind of concept of yeah, we are not we have 5 which are 5 so some people shadow. So, Swarna should have been tested quite and family. Because for that, I been personal days to who is to one. Why? One piece. First, different videos you have developed.
Thank you so much, ma'am, for this wonderful session. Moving on to the next session, safe pediatric medication practices are essential to safeguard the health well-being of children. Goal 2, focus on enhancing medication safety through accurate prescribing, dispensing and administration tailored to the unique needs of pediatric patients. Offer expert insights on this theme, I invite Dr. Suprajyoti Bhaumik sir, Professor, Department of Pharmacology and Vice President, Projects and Academics, KPC Medical College and Hospital, Kolkata, on the stage. The stage is yours.
Good afternoon, everyone. And at the outset, let me first thank LHSRC for inviting me here. Being a professor and giving a a discussion after an excellent discussion by another professor is a very difficult thing. But over the next 15, 20 minutes, I'm going to actually talk about something which you all know. I'm just going to revise few topics. Today's agenda is going to be, looking at why medication safety is important in children. What are these, do errors happen in children? Do medication errors happen in children? Yes? No? Don't know. Okay, so they happen in children. Why do they happen? And what are the few strategies which we can take care? So since morning, we've been hearing about pediatrics, and pediatrics. But please remember that pediatrics per se is not a single group. It has various groups within pediatrics. So if you see, Madam was talking about newborns, so they are a particular group. Then you have preterm newborns, you have term newborns, you have infants, you have children, you have adolescents. So why is this slide being shown? Because the general tendency that, bukhar aa raha hai and take a half paracetamol, we take the half dosing of what the adult dosing is completely baseless. Because within the pediatric age group, there is so much change in, again, physiology, the way the medications are handled, the liver and the kidney are totally developing, and they actually have various enzymes which are developing in a very different way. So I'll start with a couple of cases, and these are real cases. A 5-year-old kid, and this can happen in any of the hospitals which you work for, or maybe where I'm working for. A 5-year-old kid was actually prescribed Probazam. Probazam is actually anti-epileptic. But unfortunately, he or she was given Clozapine. For the general information, Clozapine is actually an antipsychotic agent. Now, once the dose was given to the child developed sedation, drooling, and tachycardia. Extrapyramidal symptoms appeared. And I will leave it with this question: why this problem happened? All of you are quality champions. You come from various states. Anybody from West Bengal who's here? Interestingly, Bengal is absent. So, okay, you're there. Great, great, great. So, very nice to see somebody from West Bengal. So, yeah. Why does this happen? What was the issue? I'm going to come back to this later. And this definitely looks like a look-alike, sound-alike drug. But then India, which is the pharmacy of the world in one way, is becoming the dangerous capital of the world as well, where as far as drugs are concerned. When we look into another scenario, and this would actually happen in one of the hospitals, is a 6-month-old infant admitted with pneumonia was prescribed IV gentamicin. Now, gentamicin is a very common antibiotic, given in these children, and the dose was 20 milligram. But the nurse miscalculated and started the 40 milligram ml dose. Very common. I mean, people ask me in my hospital or other hospitals that what clinical audits do. The easiest clinical audit which can be done in any of the hospitals is to look at whether your antibiotic dosing is correct in the pediatric patients or not. That is the easiest thing you can look at. Now, after the baby got this, baby developed apnea, bradycardia, and required resuscitation. Question again to this gathering is, could this be prevented? I mean, what do you think? Could this be prevented? So, we know that medication errors exist. And what is the medication error? If anybody and everybody on earth wants to get some information on medication errors, please visit ISMP, the Institute of Safe Medication Practices, which is in the United States. And it comes out with its own list every 2 months on various errors which happen in the United States. US, of course, a very bad country, not going into the reason why, but one of the reasons is because they publish their errors. And India is a very safe country because we don't have any errors, so that is what is very, very good about us. We don't have any errors happening. So what does the ISMP define medication error as? It defines medication error as a preventable event. Now, very, very important. It's a preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is still in the control of healthcare professionals, which is you, patients and consumers. Now, many of these will be OTCs, over the counter. Many of the children will receive over the counter medications and they will walk into your clinic or walk into your hospitals. Many of them will not be documented. So, what is the tune of medication errors? How much money is being spent? This is pre-COVID data. WHO and the World Bank together in 2011 looked at medication errors. How much was this costing individual countries? 188 countries, 42 billion US dollars. This number is expected to be double, more than double, around 84 billion US dollars right now as COVID has hit us, because COVID, as we all know, was a great disruptor as far as quality and patient safety was concerned. And if you look at the Indian data, very sketchy data in terms of medication errors in the country. One big study again published in Indian pediatrics from Madhya Pradesh. Who's from Madhya Pradesh here? Anybody representing Madhya Pradesh? Okay, so state of Madhya Pradesh actually, this is a very big hospital. I'm not going to name the hospital. Your biggest teaching center hospital in Indore. They looked at 1,286 patients in the pediatric ICU. Majority of them, close to 50% of them, had dosing errors. Now you must be thinking, oh my God, Madhya Pradesh is such a unsafe state. No, let me tell you, they are actually safe because they know only 50% of them are dosing errors. Many of you don't even know how much errors is happening in your own hospital. So if you go back and you look at what dosing is being calculated and how it is being calculated in your own hospital, you will be startled to look at what is the scenario. And this is our own experience for 3 years before COVID, which we published. And I thank the hospital. I come from the private background, so I really thank that, that maturity which was there in the hospital management, which allowed us to publish errors we did. 50,000 patients for 3 years in the pre-COVID era. Underreporting was massive, probably less than 100 errors reported, but majority of the errors were by the nurses. They reported the errors. As far as the doctors are concerned, the error reporting among doctors is very, very poor. This is something which we need to work on. What is this resulting in? This is resulting in that the current patient safety challenge which is on in the world, it started in 2017, is on medication safety focus. The medication without harm is current focus by the WHO in the world. I again congratulate Mr. Charsi for actually having this session here, because sessions on medication safety actually strengthen the WHO theme of medication without harm, which the WHO wants for its own member countries. So this is the current patient safety challenge. The previous patient safety challenge was clean care, safer care, where we talked about hand washing at least 15 years before the COVID-19 pandemic struck. And of course, we all know the surgical safety checklist came out of the second challenge, which was the Safe Surgery, Safe Life campaign in 2007. Now, all of you are quality champions, and I put this fish diagram, not that because I'm a Bengali and I'm very fond of fish, but this is the Ishikawa diagram where we need to actually look at when errors come in under few headings, whether I just looked at it as a medication error. What was the patient like? What was the transcription error like? Prescription had problems, whether there was a problem in administration, whether there was a problem in storage, packaging, labeling, whether there was a problem in dispensing. So my take-home message here is whenever an error gets reported at pediatrics ward, please analyze it. So we'll just go back to what happened to our two unfortunate children. We all look, the first case, this was a look-alike, sound-alike drug, and the corrective measures which we all know were that these children, these pharmacists were not aware what was lookalike. Even the nurses are not aware of lookalike sound. Now, if you really look into the tall man lettering, which has been implemented by the Joint Commission, and I'm sure it is also recommended by the NSHRC, is that the portion of the drug which is actually different needs to come into play. So we need to practice this in our own institutions so that we actually have this in practice. Pharmacists have a greater role to play. I believe this is one section in our country which is very, very neglected. And of course, well, Well-to-do pharmacists, they all work for the pharmaceutical companies, but the pharmacists, I think, require a lot of empowerment to speak to the doctors and actually talk about, especially the pediatric medication safety. Again, here, the drug dosing was given wrongly because we need to have standard dilution charts for certain high-risk medication, gentamicin was a high-risk medication. We know that high-risk medication policies require double checking, not only in papers, but in spirit, that people actually check it through the way it is supposed to be for aminoglycosides, for insulin, for heparin in pediatric products. This is one of my favorite slides, and I think you all know this. This is the reasons Swiss cheese pattern. Anytime an error happens, anytime a problem crops up in the system, it is because there are hazards in every system. And when all the hazards come in one go, then the error or the harm reaches end user, which is the patient. So what is the job of quality champions like you is to actually build the barriers where the various levels of hazards which you see right now. So very, very important issues regarding children are the dosing errors, which I've already mentioned. Commonest error is the dosing error. The other important thing, Madam was mentioning about PICU, Madam was mentioning about MICU, and polypharmacy. WHO defines polypharmacy as a condition where more than 5 medications are prescribed. So the extremes of ages, both the elderly as well as the pediatric population, they have polypharmacies. Look at the prescriptions, get them audited, because majority of these polypharmacy also happens in children. They might receive systemic antibiotics, they might have some issues with their alimentary tract, some of them might have been having other issues. So they get a lot of medications, and which can actually have a lot of drug-drug interaction resulting in adverse drug reaction. The government of India is running the pharmacovigilance program of the country, and all of you definitely contribute to it. But please remember that in your own hospitals, if there are no ADRs being reported in children, that's a great red signal. If they say koi ADR nahi hota hai, there are no ADRs in children, that's not possible. So PVPI program, we are actually trying to strengthen it in the pediatric age group. What are the reasons why ADRs are so common in children? One of the reasons is polypharmacy. The other one is definitely if they have now sulfur allergy is very common. So is allergy with penicillin. Now, many of the mothers don't know. Many of the children don't know whether they have sulfur allergy. Female sex impaired, liver and renal function. Another very, very important aspect, and this is the most important aspect, is off-label usage. Drug dosing not defined for pediatric population. And you're using 1/3 dose, 2/3 dose, 3/4 dose, whatever you feel like. One of the major reasons for adverse drug reactions in children. And one of the important things what we can do to prevent the pediatric medication errors is weight-based dosing, where you have to teach or introduce softwares for calculation of at least high-risk medication. Electronic prescribing, I think some of the hospitals in India have implemented electronic prescribing. I really wish that the government gets it implemented in many of the institutions. And now, a very, very neglected topic is medication reconciliation. I think Professor Maria was mentioning this during the lunch, that we are doing more of, part or organ-wise treatment now. The orthopedician only looks at the skeletal system. The neurologist only looks at the nervous system. And then when all of them actually write the prescription, there is no one to assimilate the prescription. This is the problem in all hospitals in India, medication reconciliation. Whose duty is it? I don't have an answer. Probably a duty of a nurse? No. Probably a duty of a pharmacist? Yes. But is the pharmacist aware of it? Or a duty of a doctor? Do it. That's the question we need to answer. Who takes care of the transition of their medication? That's what we need to know. Madam has already well defined caregiver and patient education, pictorial graphs, especially when you're giving antibiotics to mothers, especially to tell them how do you dose them. and this is extremely important for their comprehension. Please remember that one size will not fit all, and this is the mantra for pediatric safety, medication safety. If I had a dose of antibiotic as an adult, my child will not have 1/3 or 1/4 doses. I can go into the pharmacokinetic and the pharmacodynamic discussion, not the right forum, but please remember that pharmacokinetics, what is pharmacokinetics? It is the absorption, distribution, metabolism, and excretion what happens in the body. It differs amongst all of us. All the people who are sitting here, they differ in ADME as well, but the children differ maximally in it. I will actually focus 1 minute on this particular incident, which happened very recently, very unfortunate incident in our own country where few children died in Madhya Pradesh and Rajasthan. And the DGHS works very, very fast enough to issue that particular cough syrup should not be prescribed. You know, we did not require cough syrups to be prescribed below 2 years. Do we have that awareness? Do our Anganwadi workers have the empowerment to tell the people who they visit? In fact, the state of Maharashtra has actually gone ahead and banned that particular cough syrup because, believe it or not, they found diethylglycol, which is one of the toxic agents which can destroy kidneys formation. This was being prepared in Tamil Nadu, but was distributing across the state. So it's very dangerous when we're using cough syrups from not so known entities. I can open a Pandora's box here, knowing that India having more than, India having at least in paracetamol, we know there are at least 100 companies which produce paracetamol. So medication quality definitely affects safety. You need a quality control as far as when you select the brand in your own hospital. Please understand that the drug nutrition is also a very important component. If a child has shunting of growth and has been given vitamin D and the mother is feeding milk, the vitamin D and the milk will not get absorbed. If you have been prescribed tetracycline and the mother is taking, also giving the child milk, tetracycline will bind with milk. Certain drug interactions with nutrition is very, very important. India is still, some of the companies have come with child resistant quickly. This is reality now because children are able to open up a lot of packings. This is required to prevent certain errors as well. I'll end by saying that medication reconciliation is the core to prevent medication errors in our hospitals. And of course, when we talk about pediatric safety, medication safety, immunization safety cannot be cannot be forgotten because immunizations, vaccines are drugs as well. So pediatric adverse event following immunization, we have the vaccine vigilance program in the country. We need to actually look at, especially what are the vaccines which are causing various kinds of soreness, fever. Very important in a country like India, which has very different kinds of temperate and very extreme temperature climates, is the cold chain being maintained or not? So please check your own institution, is the cold chain being maintained or not? Vaccine hesitancy seen in certain section of our societies, certain religions, certain cultural benefits, and belief and also missed opportunities. So what are the important things which you can do to minimize immunization issues? One is safe administration practices, monitoring and management of AIs, strengthening of the cold chain management, and community education, which is extremely important. This is my last slide. I think India has done remarkably well with respect to the ICDS, and where Anganwadi workers have not only gone and talked about the nutrition, but also about vaccine. And so I think this requires to be strengthened for pediatric safety program. ICDS is a success story which is published in Lancet. I think India's this success model can actually be strengthened further to strengthen pediatric safety in our own children. So to summarize my presentation, I would say errors in prescribing, dosing, and administration are the leading cause of preventable harm in pediatric populations. Medication errors in pediatric populations signify faulty systems and not faulty professionals. ADRs are common in children, so please look for them. polypharmacy, female gender, and off-label dosing are one of the most important components of PDRs. Electronic prescribing system, double-check protocols, medication reconciliation, and caregiver education significantly will reduce this risk. Risk minimization in pediatric medication immunization is crucial to achieve optimal health outcome. And this will not only require medical protocols, as my previous speakers said, education of the family, use of technology, policy, and definitely, most importantly, community participation. So I'll conclude with being a medical oncologist and there are no biologically safe drugs. People ask me, what is the safest drug on earth? There are no biologically safe drugs. There are only safe physicians. There are only safe nurses, and there are only safe this all aspire to. Thank you. Any questions, comments? Okay. Thank you very much.
One small question. When assessment really is like just now you said if the reaction this means does not cause. So in situation like this, what would you advise to all of this?
Share a small story. In one of the hospitals where I was working, they said they used to put the data as well. It's still very a lot of preparation. On potential. I said one of the things that we see is children. Actually, so they believe that India is actually a natural thing. So, and what they have done is so this is not too much. Unfortunately, the people is not sharing. Sharing. People reasons. One of my thing. I get it's more or less. After I touch.
Thank you so much, sir, for such an informative session. Achieving zero harm in newborn and child health services is a fundamental goal to ensure safe, effective, and high quality care. Goal 5, which focuses on reducing risk for small and sick newborns, is central to safeguarding their life and future well being. To discuss on this issue, I would like to invite Dr. Shobna Gupta, ma'am, DC and in charge, Child Health and RPSK, to please share her insights with us all today. Over to you, ma'am.
So very good afternoon to everyone. I think I'm the last speaker for the session, so I hope everyone is well awake, especially the last liners. You could come forward, a lot of seats are there. So I can see many familiar faces from the child health as well as from our state program. So definitely it's a pleasure to be here, and I congratulate the Quality Division NHSRC for organizing in spite of all the things going on being postponed. Today also a lot of hurdles came right since in the morning, but they managed well. So it's my pleasure to be here, especially entrusted with the responsibility be safeguarding the interest of our children and newborns. So having that important part, as you all are there along with me, and the very theme of this today's, we must be having been discussed since morning about the safe care for every newborn and child. So although this is a very one-liner theme, but as you know, safe care, this is a very broad. Safety means each and everything right from the I just heard the last lecture. It was good. This was all about drugs and medications, and you must have listened to the all the speakers who talked about goals. So the safety does not encompass only the drugs or the protocols. To ensure safety, it covers overall spectrum, which we say from infrastructure to the capacity building to what facilities we are giving, the logistics, availability of logistics, so the protocols, all the associated engagement of who are involved. Basically, it's paramount of quality. If we say so, we ensure, and in our quality protocols also, everything is all about actually safe care. So if you ensure quality, you're automatically ensuring a safe care. So definitely this safety begins right from the first birth. The moment the child enters or takes birth into the world, it's our responsibility, the joint responsibility that we adhere to it. And as we say, that no harm. At least if it can't do any, benefit, at least zero harm for everyone. So today I'll be just briefly telling you about the GOI initiatives, which my child and state nodal officers are already aware. So what is the whole government efforts are there to ensure their safety, and also in spite of all that we are having the challenges because of certain gaps. So I'll be briefly talking about that. As we know, just a comprehensive this thing that right now we have the 3 levels of the newborn care. We have around 23,000 newborn care corners. At the CHC and FRU, we are having 2,700 NDSUs and almost more than 1,000 units of special newborn care units, where we started, to first unit in 2005, 20 years across, we have more than 1,000. And definitely, if we say the admissions per year which we are getting in these SNCU, that is, upgrading year by year. So that is showing that we are saving more and more preterm and low birth weight babies as the time is passing. And definitely with that comes the responsibility of the safety and the quality again. That to provide that optimum care which every newborn and preterm requires. Our discharge rate definitely is improving, but with a 84%, but we aspire to achieve even more than 90% with the growing times. And this level of newborn care gives the holistic approach with the having the district early intervention centers for linkage, for the follow-up, for developmental delay, the eye and the vision, then the quality certification, which is happening under Muskan, and NCOS is a broad category. Then linkage as they, telling about the community engagement with the parents. And definitely very important part is about the
data process which has to be there, the data management, and how to utilize that data for the improvement in the processes. So as we said, the first and foremost important thing is to have the skilled human resource. So we have the norm that there has to be, in the as we day by day we upgrade our standards. So as for IPHS, and we have upgraded this in our operational guidelines also, that there has to be a bed nurse ratio 1:3 in the SNCU. And you must have heard about the mother newborn care unit, how the mother can take care of the baby. So it is very important to have the skilled human resource, and we have issued guidelines from time to time to not to rotate the staff who is being already trained, and to regularly conduct the refresher training courses for that staff. Keeping that in mind, as we know, the basic paramount of NSSK and the FBNC training which we are having in the SNCU, part of that, taking care of that, special emphasis on the preterm and low birth weight, we are coming up with the oxygen module, separate module for the staff is already working, because we have introduced CPAP. And in CPAP, it's very important that we take care of the minute things which need to be there while administering CPAP. If we are giving CPAP and the oxygen is 100%, humidification is not happening, or we are not monitoring the pressure, it can give the more harm rather than benefit to the baby. So it's very important to adhere to the protocols. So we try our best that we introduce the protocols in the simplest language, which our staff nurse, doctors, pediatricians working in the newborn care units can take care. And we'll be doing this again. We will be introducing this in the LMIS format also, so that you can just go to our website, NHM or the SNC portal, and you can read the manual before coming for the physical training. So we'll be having a 3 days package on the oxygen module and 1.5 day covering the developmentally supportive care, the nurturing care components, how to give that in the mother newborn care unit, and how the mother and the family needs to be engaged. So these are the special emphasis will be coming up soon in this year. Then again, as we know, it's very important the triage, as the parents often complain that our child was not seen of. So it's very important to sort out what is an emergency and what is a non-urgent. So, that clear guidelines to having a warmer at the entrance of the SNCU. This training of our HR for the early identification of the high-risk babies, and in case further referral is required, then how to establish that, strengthen that referral linkage. If you have seen the baby in the NBCU, but however, as you most of the times the complaint we receive, or which the vigilance comes, or we lose the baby, referral. You have seen the baby, you have done something. However, we do not establish the referral linkage, or we do not confirm that the baby has been received at a center and a care has been received. So it adds to more it leads to worse outcomes, as well as so much of legal hassles for all of you and to the family. So, and a baby, even if reaches, even if survives, there are so bad outcomes. So it's very important to establish and close the loop in a timely and efficient manner. Safety in clinical practice, I'm sure so many people, I was saying the agenda must have talked that there needs to adherence to the defined protocols. We have plenty of defined protocols. They are pasted in SNCUs. We know the guidelines, the rational dose calculation. In one of my field visits, I won't name, but I was shocked sometimes, to see, in spite of being training, I just picked up the case sheet and the baby was being given IV Dexona newborn for no reason, for about 60. I don't know what they interpreted. So it's very important to keep them mentoring, to keep them, refresher skills are there, 100% oxygen running, or some steroid being going without even it, and most of the common enteral feed is being not started, only IV fluids are being given. Even today, scenario in a good SNCU, we can see that. That leads to overburdened SNCU itself, more infections. So please ask your staff, and just check when you go to their field visits that the simple things are being done, the follow-up is being ensured, and the simple things of oxygen concentration, the charts which are being followed, very important, antibiotic policy, these are being followed.
Very simple technique like breastfeeding. We are saying, I think, from centuries, from Mahabharata, from Ramayana times, that but still it is so difficult to achieve. We can see our NFHS data. So we need, and sometimes I feel with encouraging time, and it is not restricted to only one class. The more it is being there everywhere, somehow there is a resistance from feeding, in spite of the positive, culture being provided, leave being there. Still, people are somehow resistant or not very forthcoming, especially the sustained feeding up to 6 months, even if started. So this requires, I think, social behavior change, which everyone needs to talk about. Everyone knows breastfeed is good, but I think it needs to bring about a common message from all of you. It's not that only nurse is responsible for saying this, going there when you're going, checking the practices, how it is actually happening, or it is only on the paper. So that's very important. Define housekeeping protocols, hand hygiene. Again, my previous speaker also wrote simple thing, whether it is actually being happening or not happening. And we have seen even the pediatricians trained our resident doctors. I've seen once the experts are out, faculty is out in the night, they just go and treat everything that causes the infection still. So it's a behavioral change practice which need to be inculcated by regular talking about in your routine when we are taking rounds, when we are going for inspections. So generally talking about breastfeeding, hand hygiene, which is kangaroo mother care as a whole. So these things need to be more and more promoted, and everybody I think needs the benefit of colostrum and kangaroo mother care. Because everything, I think guidelines, I really doubt that if anything, we don't have a protocols and the guidelines right now. And the endorsement is there that what to do while inside, while coming to the SNCU. And our facility-based newborn care manual is actually beautiful, which covers each and everything. There are annexures for housekeeping routines in a very simple language. For the audience who are not, from the government setup, everything, even in the new operational guidelines, we have included the things like that, which will be released soon. What are the specifications for the KMC chair? In case you have some problem, you can go through it. How should the cloth should look like? What are the options are there? You can choose from whatever is there in the state. But there are suggested, these things have been added so that you can go for it whenever you require. Similarly, infrastructure support. In our newer guidelines, we have upgraded our infrastructure support because there is a bed occupancy ratio, if you see at the national level, is 102%. In some of the states, it's up to be 140, 150% going. So definitely our beds are increasing, and definitely one warmer and newborn definitely should be practiced. IPC guidelines have to be practiced. We have now upgraded for a defined space which will be there in our mother newborn care unit and SNCU, so that there's an ancillary space for everything for the mother and the baby, and we can follow the IPC guidelines, friendly child-friendly infrastructure, and continuous power supply, continuous water supply. Simple things, basic things, but very important. Maintenance. You can see in few of the last months, unfortunately, we have some bad incidents, and you can see the maintenance is a very important issue because most of our government facilities, they run 24/7, and an equipment is never of the actually grade. So it leads to sometimes short circuits, the compressor being blown off. Yesterday, unfortunate incident in the Rajasthan, even in an adult ICU. So that shows that equipment maintenance is one of the very important things which needs to be taken care of while managing the fire drills, the oxygen CO2 extinguisher. So these are all there in our NCOS guidelines. And especially for newborn, the safety during referral transport. Many, while my practice as a pediatrician, we used to see that most of the baby which used to come to the emergency, they were totally hypothermic. Actually, you could not do anything, or even if you are doing, the baby will have the bad outcomes and logical outcomes. So, ensuring that referral transport, breastfeeding, and temperature maintenance during referral is really important. And this data tracking and outcomes. For this, we have our key performance indicators to see how we can actually see this. So we have our in the guidelines the key performance indicators, and we can do data triangulation even at our own level. Our stage nodals can do, because you can actually we have the collecting data, but data is of no use if it's not acted upon. So if you are having a high antibiotic usage to the tune of 90%, you might be saving many babies. But have you actually seen how many sepsis cases you are having? Or if how many low birth weight versus the KMC rate you are being given is having? So these kind of data triangulation and analysis will actually help you to improve and do those short quality improvement cycles within your unit and improve the simple practice which can bring about the change. So track this process and the outcome indicators. Make a policy for your state, for your district, and for your facility. And also very important is to track the follow-up rates. We have seen we are saving more and more babies, more and more preterm, more and more oxygen usage. It's leading to more and more ROP also. So actually, do we have a policy for ROP screening? Have we actually looking for the routine of every baby? How many babies are actually coming back for follow-up? Keep data of that. And process the ways where you require the government support and what infrastructure or policy support you require. Please raise. We are also trying at our level how to streamline this process. But you also have to work at your level, and even when you're going for quality assessment, raise these issues. So definitely what I was actually talking, there has to be a clear roles and responsibilities and accountability at every level, whether it is an administrator level, whether it is a facility head, as a newborn unit lead, the clinical or neonatal unit head, the nursing, and definitely the biomedical equipment management. So everybody has to have a clear roles and responsibilities, what they need to checklist, and what are they supposed to verify. That would actually help to streamline the process and have our system more efficient. One of the most important thing, as I think the last speaker was mentioning about the community engagement, the parental engagement, which we often forget. Mostly in our SNCUs, the mother comes, visits, she goes back. But do we actually counsel her enough so that she can take care of that preterm baby when she goes back home? So this efficient community linkage is very important. But that community linkage is not only with mother, that is with the family, that is with the ASHA who is having the home visits when she goes home, that is with the ANM and the CHOs of the nearby arm, which is actually, will be treating the baby as and when the baby would be having followed up. And even we are in the revision of our home-based newborn care guidelines are being revised. So there also will be strengthening more accountable role for our ANM and CHO so that the whole team can actually help in the better community linkage and the community follow-up. In our SNCU database also, we saw that the facility follow-up is actually less than 50%. And the community follow-up of those is even lesser. So it's very important to ensure that follow-up for our intact development, growth assessment, and all babies are actually which are getting SAM or MAM later on are these babies which are getting discharged. So this 20 to 30% of the whole birth cohort is actually the most important category which we need to follow up after discharge in the community. Ultimately, they are the ones who are getting readmitted in our PICUs. They are coming back to our NICUs and the pediatric ward, and they need more care. So there has to be a good linkage between the community team which is going and our doctors, and they are not separate. So it's very important to sensitize the doctors, even in the medical college, the tertiary care, and our residents, and that it's that you treat the baby, you discharge the baby, and your job is off. That's not the case. We need to have a continuum of care. So that message needs to be inculcated definitely. And one important thing, last important thing is about the community death review, which we have there, but we have very the performance in that death review is not up to the date which should happen. Once you start auditing the deaths, your reporting, recording, your clinical monitoring, automatically the quality improves because then you know where is the reason. So definitely safety culture needs to be embedded, and education is a key for that. So as a practical aspects, as you have seen, regular safety audits for even the natural disaster, we have seen the incidents, how they are happening. So these fire extinguishers, oxygen cylinders need not be kept inside the SNCU, those protocols, medicine doses, we have talked about regular monitoring and use of appropriate accessories and consumables. That's also very, very important that you use the right consumable in the machinery. Otherwise, it can lead to difficult problems. I have seen this baby, a simple entity like IV fluids, if it was not taken care of, lead to the thrombotic hand and the baby had the gangrene that I have seen in my practice also. So simple things can actually cause a much problem. Very common scenario while giving a CPAP for long time, the nasal septum, irreversible injury. So just you have to remove and put the nasal saline drops every 4 hours. Simple entity. They need to be taken care of, and hand hygiene, housekeeping protocols. So I think continuous surveillance for adverse effects, adverse events, definitely they actually help to see and to audit for your mistakes. Sometimes and the times we have a motto, do no harm. So it's always the unintentional. But we need to be aware so that the next time that mistake is not repeated, that error is not repeated. So definitely, as I told, we always have to mitigate these challenges. We continue to strive harder and harder, learn. And I think medicine is one field where we keep on learning till we actually live. This is one field where we keep on reading and learning and making others learn along with us. So going with that, we have updated our operational guidelines. As I think most of the things I have already told in between that quality certification for it's already happening. The Muskan would be coming under NPOS and home-based newborn care. We are already going to scale up 2.0 so that more strength and safety this thing are being given. We recently released our stillbirth surveillance guidelines for which our regional workshops are going on, and that is also one of the aspects the safety only. How to prevent? What are the 4Ds where you can delays, where you can actually work upon? So strengthen the mentoring and the monitoring component is very important because that helps in the continuous capacity building and education. And one platform which can be used for this is the tele-SNCU and the tele digital system, where we can actually, we have few examples in our country where one medical college is actually mentoring 28 and 30 SNCU. We have in Nilafgar, we are in Chhattisgarh, we have one in Nagpur, where they're actually mentoring 28 and 30 SNCU through a tele-SNCU and providing that hand holding to the nurses and the doctors in the other SNCUs also. And that platform is also utilized not for clinical case management, but for the capacity building also. So these kind of things actually help us to, give a safe journey for every newborn and child of country. Thank you. I would be happy to take any questions.
Thank you so much for this insightful session, ma'am. This brings us to the end of our technical sessions. Thank you for your enthusiasm and dedication so far. We had a series of poster presentations displayed near the reception area. Heartfelt appreciation to all the participants for their exemplary efforts and valuable contribution through their poster presentations today. From these, the top 3 posters have been selected. The second runner-up goes to, any guesses? The second runner-up is the state of Uttar Pradesh. Congratulations. I request the representatives from the state of Uttar Pradesh to please come forward. Congratulations, Team Uttar Pradesh.
Sir, please may I request you to please come forward. And ma'am, I request Dr. Aarti Maria ma'am as well to please come forward for further felicitation. May I request Dr. Shobna Gupta ma'am to please come up on the stage. Next up, the first runner-up for this presentation, poster presentations. Any guesses, audience? The first runner-up is Gujarat. Congratulations, Team Gujarat. I request the state representatives to please come forward. Yes. Congratulations, Team Gujarat. And the final, the winner for the poster presentation. Any guesses?
Yeah, please state the last letter.
So the winner is Jharkhand. Congratulations, Team Jharkhand. I would like to kindly invite the representatives from the state of UP to please come forward for a picture. Ma'am, the missed, yes. Once again, congratulations, Team Uttar Pradesh. Thank you so much, everyone. We also have the participation certificates for all those who took part at the poster presentation. Along with that, the winners would receive their certificates later on. It will be dispatched to their respective states later.
Now, I would like to invite Dr. Priyansha Mahindru ma'am to please deliver the vote of thanks.
Good evening, everyone. So, as we draw the curtain on this year's observance of World Patient Safety Day, I feel deeply honored and privileged to deliver the vote of thanks on behalf of Quality and Patient Safety Division. First and foremost, I extend my heartfelt gratitude to our esteemed dignitaries, Ms. Aradhana Patnaik ma'am and Sri Saurabh Jain sir, for graciously accepting our invitation and for taking time out of their demanding schedules to be with us today. Ma'am and sir, your valuable presence and insights have added immense value to this event. I also wish to extend my thanks to all speakers, the state representatives, and representatives from various organizations who joined us and enriched this event
with their participation. A special and sincere word of thanks to Rajiv Patel, sir, advisor QPS, for his steadfast guidance, constant encouragement throughout planning and execution of this event. We are equally grateful to Brigadier Sanjay Bevija, sir, Principal Administrative Officer, and Mr. Sarsi, admin team, and IT team for their exceptional coordination and unwavering support at every stage. Their contribution has been critical in the seamless organization of today's program. A heartfelt thank you to the entire QPS team for meticulous planning, tireless work, and excellent coordination. The commitment to uphold the value and objective of this event is deeply appreciated. Furthermore, I would like to acknowledge the continued and wholehearted support of NHFW staff and support staff. Your behind-the-scene efforts are deeply appreciated and were vital to the smooth conduct of this event. To everyone who contributed both on stage and behind the scenes, thank you for making this event a resounding success. Thank you and have a pleasant evening.
This brings us to the closing ceremony. Ladies and gentlemen, as we draw the curtains on this remarkable event, we want to express our deepest gratitude to each and every one of you for being a part of this national level celebration of 7th World Patient Safety Day. To conclude our event, I would like to thank our chief guest, all our key dignitaries, eminent speakers for their technical sessions, representatives of Ministry of Health and Family Welfare, representatives from all the states and UTs, and representatives from the development partners and academic institutions who joined us on this occasion and made this event a success. A heartfelt gratitude for all the divisions of NHSRC from whom the advisors joined us for the event today, the IT team, our admin team, and the team of NIHFW for taking their precious time out and making this event possible. At last, I would like to congratulate and thank the QPS division team members and my co-host of this event, Dr. Akanksha, as without them, this event would not have been possible. As we conclude, let us reaffirm our commitment to safe care of every newborn and every child as a vital part of universal health agenda. By cultivating a culture of accountability and safety, we can enhance quality of care and prevent harm from the first breath of life. Strong collaboration among healthcare professionals, policymakers, and communities is essential to achieve this vision. Together, we can build resilient health systems that ensure the well-being of every newborn and child. Thank you, one and all. Now, I request all of you to join us. Sorry. Once again, I thank you so much. Have a great evening ahead. Jai Hind. Thank you so much. The tea is arranged at the cafeteria. Thank you for being with us today.